So, good evening, everyone, and welcome from ORTHO TV. To further this program, I'll hand it over to our moderator, Dr. Sergio. Over to you, Dr. Sergio.
Hello. Hello, everybody. It's a big pleasure for me to be here. This is a very special day to me. As you know, I'm Dr. Sergio Rovinsky from SHOULDERPLANET here from the city of São Paulo, Brazil. And today we are going to have a very special webinar, very special to me because this is a topic that I've been doing for a lot of time. And as I always say, this is the topic, nipple plating of the humerus, who opened the doors of India to me 12 or 13 years ago. So it took me a lot of time to organize it, but now we have an outstanding group of panelists, and I would like to introduce you all before we start this lovely webinar. So today we are doing a webinar on biological fixation of humeral shaft fractures with intramedullary techniques and with anterior bridge plating techniques. So I have here a beautiful number of panelists, and I would like to introduce them because we are really in the middle of the sky because of so many stars. So let me start with India. From India, we have here Dr. Shiva Shankar. Dr. Shiva is not only the president of Indian Orthopedic Association, but a very skilled nailer. He's very experienced in nailing, and he travels all around India for many years to teach young and even experienced surgeons about his knowledge on nailing in all of the bones of the human body. But today we are speaking about the humerus. Of course, he's going to speak in a minute. From Argentina, we have a very good friend of mine, Dr. Diego Gomez. Dr. Diego, he's a shoulder and elbow surgeon from the city of Buenos Aires in Argentina. And he's a member not only of the Argentinian Shoulder and Elbow Society, but also a member of the Argentina Orthopedic Trauma Association, and he's very active and a brilliant surgeon in all of the fields of shoulder and elbow surgery. From Brazil, our place here, I have two special colleagues. First of all, I'm gonna on the right side of me, Dr. Luis Fernando Coco. He's a good friend of mine. He's professor in the orthopedic trauma department of the Federal University of São Paulo, from which I come, and I spent 15 years of my life over there. And I have the big honor, the big pleasure to introduce to you this man, Dr. William Belangero, which is not only the president of Brazilian Orthopedic Trauma Association, but he is the inventor of anterior bridge plating. So it took me, in synthesis, 15 years of my life to get to this moment. So I really have to thank you all. I can guarantee to you all that we have many people seeing us. I have been receiving very positive expectations in my WhatsApp email last few days. And I just would like to mention one point before we start and you guys introduce yourselves. I have been spreading my project amongst a lot of physiotherapists in India too. So we have many physios here now, which is very, I would say, relevant. And I have a good friend in India, a very talented girl. She's named Dr. Devayani Thakre from the city of Nagpur, and she has been helping me spreading my project amongst the physios universe. So Dr. Devayani Thakre, thank you very much. We are counting on you for the next events. So having said that, I would just like you guys to start speaking. We will start with Dr. Shiva, but before that, Dr. Shiva, just say hello to everybody before we start, and I would like just the panelists to introduce themselves.
Hello.
Very fastly.
Thank you, Sergio, for having me here. Thank you very much.
Okay, Dr. Belangero, just say hello to everybody, please, because we have many people.
Hello, everybody. It's a pleasure to be here and to share our experience with you.
Okay,
Thank you very
Coco.
much.
Lovely. Dr. Coco.
So, hello, hi. Can you hear me?
Yes, but it's not, it's a little bit far away.
Really? So what about now? Better?
Okay, now you can speak.
So it was a pleasure to be here and share some
Lovely.
experience with you. Sergio made all the introductions, so I'm ready to start.
Okay. So Diego, very nice to have you here, okay? And then we can start with Dr. Shiva. So Shiva, we are not listening to you. You can please share your screen.
Yes.
And then you can start.
Can you see my screen, Sergio?
Yes, you can start.
Okay. Thank you very much. Thank you, Sergio. This is my brief introduction, which already Sergio has given. Friends, Sergio is a good friend of India. He has come so many times to India, Nagpur, then Vijayawada, Chennai, you name the place he has visited, Agra. He even came to Sholapur when I was the president of the Maharashtra Orthopedic Association. You can see me in the front row along with Sergio and Vittori. He gave the prestigious oration in the Maharashtra Orthopedic State Conference on the anterior bridge plating, and he has propagated widely this technique in India. I have been meeting him at many platforms. I met him at CASCON, that is orthopedic meeting, arthroscopy meeting at Bangalore. Then I also met him in Nagpur during the 75th birthday of Dr. S.S. Babulkar, associated with a academic activity. Friends, these are all the members of India Earth. Sergio will be knowing all of them by name, who all came together for a photo shoot when Sergio came to Sholapur. And thanks to Sergio for this wonderful efforts you have been taking to propagate this knowledge to all of us. Friends, if you read one of the sentence, I am the past president of nails. Probably only in India we have this association. Nowhere in the world we have an association only dealing with the interlocking surgery, because interlocking surgery comes under trauma in many of the part of the world. But in India, we have different problem that our stature of the patients are small, the canal is narrow. So our problems were different. Hence, we started this association way back in 2000. Now it is 21 years old association. Coming to my talk. Here is an example of a lower third humerus in a 18-year-old adult treated with a closed nailing. At 6 weeks, you can see beautiful consolidation with good function in the shoulder. I'm only intentionally showing the function of the shoulder because this is the one which is being blamed majority of the time by those who do plating. This is an advocate. He had a fractured humerus. See the incision, keyhole incision through which I have done the nailing. And you hardly can make out the incision when the patient came for implant removal. Almost always I do the implant removal, and this is the function about 5 years after the implant removal. Recently, in 4 or 5 years back, I have taken this clinical picture. Another patient, see the condition of the skin over the shoulder. He had a proximal humeral fracture. Again, I have treated with a proximal humerus nail with interlocking. And you can see the function. I normally start the shoulder function as early as possible because majority of the cases I operate under shoulder block, that is the Bayer's block. So the patient will not have pain in the initial post-operative period for 1 to 2 days. That time I mobilize them and they will get extremely good function at the end of the treatment. See, after the fracture is consolidated, see the function of the shoulder. Again, as I said earlier, I intend to remove all my implants which I have put them. Earlier, I was doing nailing only with 1 screw above and 1 screw below, but now I feel that 1 screw above, 1 screw below may cause some torsional problem, especially if the nail size is thinner than the canal size. So I have switched over to 2 screw system, 2 proximally and 2 screws distally. This is a case, so the whole video is available on YouTube, 1 hour video. The surgery and the implant removal videos are available. Again, this is after the implant removal, after beautiful consolidation. See the function of the shoulder. So this is after the implants have been removed. These pictures have been taken. You can hardly make out the incision with this small one incision, I've been able to do the proximal locking and distal locking in the distal part. So 2 screws could be put just by retracting the small incision of 5 to 10 millimeter. Again, as I said, this whole video is available on the YouTube. You can search for that and you can get them. This is an interesting case. A fracture shaft humerus came to me almost about 7 or 8 days down the line. He had consulted so many people at different cities before coming to me. This was the wound which precluded the earlier surgeons to do a plating which was advised to him. See at the elbow, the bad skin, see at the shoulder. So this is on table. The very next day I took the patient for the surgery. This is the shoulder. I wrapped it up totally with a sterile drape. And my technique I'll be showing in detail later, but normally what I do is I pass a 1.5 millimeter guide wire. Over that I pass a cannulated drill bit, then take out the guide wire and pass the guide wire for reaming. Once the guide wire goes across the fracture site, I ream them properly canal, then I insert the nail and do the distal locking first, extract the nail to compact the fracture. As you can see in this case, the fracture has been compacted. Then I will go ahead and do the proximal locking. And when I do the proximal locking, I always see that the nail is well buried, at least about 5 to 7 millimeter underneath the bone. See, at the end of the surgery, 2 small incision for proximal locking. This is the 8 millimeter incision for the nail to be inserted. This is the immediate post-operative picture in the same patient. And this is on 3rd day when I took the patient for dressing. The wounds have started healing. This is on 3rd day, the picture. You can see the wounds where I have put the stitches. Then at 10th day, when the patient came for stitch removal, this was the condition. And I did the stitch removal on 10th day. This is at 1.5 months. This is at 3 months. When he came for 3rd month follow-up, this is the function he had got. He had some pain at the fracture site. So I advised him, because I was not happy with this picture. So advised him PRP injection. PRP is platelet-rich plasma injection. And he agreed and he came after a month. At 4 months, I injected the PRP at the site. It was more on the medial side. You can see the bone more on the lateral side, but it was less on the medial side. So I injected mainly the PRP more on the medial side. And this is just after a month. He was totally pain-free. This is 2 months after the injection. This is 8 months after the initial surgery. This is 1 year after the initial surgery. You can see beautifully the fracture has consolidated. And as I said earlier, I almost always remove my implants. I don't want them to be left in the body. So they don't have any work in the body. So I have removed these implants. This is the function after 1 month after the removal of the implant. Friends, I will make a bold statement here. I have been a nailer since beginning. I have been doing lambda wires between 89 to 96. Why not before 89? Because I was not involved in orthopedics. I was just a medical resident at that time. So I joined orthopedics in 89, and since then I have been using this similar to K-wire, but they're little more flexible and malleable. They're blunt at the tip. I use them for doing the humerus nailing. I also do extreme nailing for the distal third humeral fractures, thanks to Sergio. After interacting with him through IndioOrth, I have done quite a few number of anterior bridge plating also with equally good results, even in all of them. So this is the effect Sergio has on me like a nailer. I am an ardent nailer, but definitely I do other type of surgeries. Friends, in general, humerus can be treated conservatively with a plaster, and that is the regular mode of treatment which we are doing. Thanks to lockdown, I had the opportunity to treat few cases with functional cast bracing as well as humerus cast. This is a joke about the humerus fracture. As long as 2 ends of the fracture humerus are in one room and an orthopedic surgeon doesn't enter the room, the bones will unite. This is what everybody says. In general, if at all surgery is needed, plate and screw fixation is the established procedure, still carried out as a routine in many centers because of the problems of the interlocking. I have kept them in the inverted comma. They are extremely very important. That is the part of my talk. The problem with humerus interlocking nailing about that is not many articles have appeared in the journals. Many report more complications with nailing rather than plating. Overall, there is a feeling that plate fixation is far better than a nailing. My talk is to remove those myths. I shall not talk bad about plating to prove my point. I am an orthopedic surgeon, as Dr. Tanna says, and I also treat them with other modalities like plating, anterior bridge plate, and other methods when indicated. So let me talk about how to do a proper nailing rather than talking about bad things about the plate. This is a landmark article which reviewed many of the humerus fractures, and this Mac came out in the JBJS. The complication he listed were interlocking nailing of humerus has been said to be the technically more demanding and having high rate of complication. These are some of his conclusions. High chances of iatrogenic radial nerve palsy, severe impingement at the shoulder, adhesive capsulitis or shoulder stiffness is a known phenomena. Intraoperative comminution happens at the fracture site. Non-union chances are very high. These are the complications he enumerated. Probably this is the paper which has done more damage to nailing than anything else. Friends, I believe that it's the technique. All surgical techniques are good if well executed, knowing the principle behind it. They will definitely end with good result. Aim of our surgery should be to avoid complications, as many are due to technical problem and not due to interlocking nailing per se. So that is the reason why I said, let me talk more about how I do my surgery rather than anything else. You can see, in the proximal head, I insert a joystick K-wire. Percutaneously, I insert in the head. This is only to have a control over the rotation of the head. So this is how the K-wire, which is 2 or 3 millimeter, you can see I can rotate it by 90 degrees. So without changing the position of the C-arm, I can take AP and lateral picture of the proximal medullary canal of the humerus. That is the reason why I use this K-wire. This is a 1.5 millimeter K-wire which is used for 6.5 millimeter cannulated screw. I pass it in the center of the proximal medullary canal and I confirm it both in AP and lateral picture. Then only I will drive it more distally. So I am confirming that my guide pin is at the junction of articular and non-articular portion. Now I am seeing that it is entering into the medullary canal. Then once that is confirmed, I take a small 8 millimeter incision, very small incision I take. Then up to the bone, I go with a hemostat artery forceps and open up in line with the fibers. This is very important. Open up in line with the medullary fibers of the rotator cuff. Then over the guide wire, I pass a 4 millimeter cannulated guide wire. See, I am doing to and fro motion, not drilling with a power drill, because that will be always too much motion. So this will not entangle the soft tissue. Then I will remove this guide wire and through the drill bit, I'll pass the long guide wire for reaming purpose. I am passing the long guide wire now. I will use the drill bit as a joystick to manipulate the proximal fragment. Assistant only gives traction. Assistant will not help in the reduction of the fracture. I have the control over the proximal fragment. I manipulate the joystick of the drill bit. Then I will pass the guide wire across into the distal fragment, which I can feel and also confirm under C-arm. Now the guide wire has gone across to the distal fragment. Now once the guide wire has gone across to the distal fragment, I enlarge the entry with 8 mm cannulated owl, which comes with the set. Again, you can see it's a to and fro motion. If you rotate it with a power drill, all the soft tissue will get entangled and they will get damaged. So by to and fro motion, I am going to make an entry, and once that is done, I always ream. There is no role of unreamed nailing. You have to ream to fit a thicker size nail, and here you can see both fingers of the assistant, they are stretching, and that will prevent the soft tissue to get entangled with the reamer. And also when you are going across the fracture site, reaming should not be done. So this is very, very important. Again, as I said earlier, the whole YouTube video of the whole surgery is available on the YouTube. Yeah, I would request you to go through this YouTube video and find out more about this case. Some of the important things are you have to operate from the head end of the patient. So the C-arm comes from the opposite side, and both and AP lateral can be taken in the same C-arm position without moving the C-arm. As you can see, I normally pass a guide pin into the joystick into the proximal fragment. Assistant also will just give a traction from the distal end. Friends, big surgeon make big incision. Gone are the day. It's the era of keyhole surgery. If you make big incision just to see the rotator cuff and then make an entry, you will land in stiffness definitely. They take a lot of time to heal. Always better to go for a keyhole surgery. It's a big no-no for opening up the shoulder. As I said earlier, I pass a guide pin first. Once the guide pin is properly positioned, I take a small incision. Over the guide pin, I drill with a 4 millimeter cannulated reamer. Then I take out the guide pin, and through the cannulated drill bit, I pass the guide wire, reduce the fracture. See, confirm it AP and lateral. See that it is going properly in the center. As I said earlier, nowadays I'm using a joystick so that my life and the surgery can be done quickly without changing the C-arm position, or the assistant need not have to rotate the arm. Even if the assistant rotates the arm, the rotation will happen at the fracture site. That's one of the reasons for the radial nerve palsy. So that can be also avoided. As I said earlier, I use the centering out again with hand only and enlarge the entry site. Always support the distal fragment with a small towel, because there is a small pillow between the shoulders. So the shoulder is elevated. So the elbow also should be elevated when you are doing surgery. Assistant should give gentle traction to avoid radial nerve palsy. And when you are manipulating the fracture, gentle manipulation is very, very important when you are passing the guide wire across the distal fragment. Better is used the drill bit only as a joystick. As you can see in this case, I'm using the drill bit itself as a joystick and passing across the distal fragment. Excessive traction and using the tool, again a big no-no. They are all not required. Always a gentle traction just to distract the fracture site, few millimeter, not more than that. Then you get the guide wire across into the distal fragment. Then always ream. Reaming is to fit a thicker nail, which increases the contact, it decreases the working length, so that will be much more stronger. Always use a reamer. Coming to the reaming principle, reaming is done to fit a thicker and stronger nail. Better to be done with a flexible powered reamer rather than straight reamers. Always start with the smallest reamer. I normally start with 5 or 5.5 millimeters reamer. Then I gradually end up reaming up to 8.5 or 9 millimeter. Always ream over a guide wire, because if by chance the reamer breaks, then you can take it out. When using a detachable reamer, you have to use a beaded guide wire. That has to be kept in mind. Run the reamer only when there is resistance. Otherwise, just with the hand, you can push the reamer across the fracture site. Do not ream across the fracture site. Again, it might cause the entanglement of the radial nerve, especially if the reduction is not proper. So never ream across the fracture site. You just push the reamer into the distal fragment. Control of the reamer should be in the hand of the surgeon. Why I am telling is, in India, we almost use, many of us use the Manman reamer, where the foot control is there. Though there is a hand piece, the control of the drilling is in the foot. So the foot control should be with the surgeon, not with the somebody else. When you are passing the nail, always keep a look at the fracture site. This was the case. I have passed the nail across the fracture site. Such a beautiful reduction done. But when I was further hammering, you can see the fracture was getting distracted. The reason is, friends, the humerus is slightly curved distally. Then, though you have done the reaming with a flexible reamer, when you pass the straight nail, the nail cannot negotiate this bend. So that when you hammer that, distraction will happen at the fracture site. So always keep a watch at the fracture site when you're reaming. In this case, I used a thinner nail and I could do the surgery. Again, fractures comminution is another thing which is blamed. Always see that the fracture is reduced before you hammer. This is one of my own case. 2005, I was operating. It ended in comminution. because you can see there is an angulation. This should have been avoided by taking one extra shot in the C-arm, and I should have aligned it properly and passed the nail. Again, your guide wire in the proximal canal should be in the center, both in AP and lateral. Here you can see it is eccentrically placed. What had happened, since it was eccentrically placed, the flexible guide wire could bend and go into the distal fragment. The flexible guide wire has gone and it has rimmed. But when I pass the nail, you can see there is a iatrogenic combination. So that is the reason why I'm insisting that your guide wire should be center both in AP and lateral. Even if you want to take the entry from the top, from the articular surface, especially in proximal humeral fractures, don't worry. Go and take an entry from the top in line with the center. Then use judiciously your C-arm. The C-arm can be kept in 9-inch mode, which doesn't show the distal locking properly. By making in 6-inch mode, the hole can be better seen. By making in 4.5-inch mode, it can be still zooming can be done. Always use a sharp K-wire, and because the humerus is distally triangular shape, it slips. So make with a small sharp K-wire a dent in the anterior cortex. Then you use a owl to, by to and fro motion, make a hole in the anterior cortex. Then you insert the K-wire rather than the drill bit. Because it's a small incision, you can do the drilling with a K-wire and pass the K-wire and drill the distal fragment. And I almost always do the anteroposterior locking, so I don't find any problem with the C-arm in the same position. After having done the distal locking, always extract the nail to compact the fracture site. This is how I normally extract the nail to compact the fracture site. I already done the distal locking. You can see one of the hand is pressing the shoulder, giving a counter support, and extraction is being carried out. That will compact the fracture. So this is the preoperative picture. This is after compacting the fracture by few extraction after distal locking. You can see the fracture gap has been reduced. Again, in this case, again, this YouTube video is available of this patient. There was a gap here. After extracting the nail, the gap could be totally reduced to 0. So this is very, very important. And always there should be, the nail should be kept slightly underneath the bone. It should not cause impingement. So when you select the nail, your nail should be slightly shorter, so that you should measure the gap at the fracture site, and extraction back. Even after extracting, the nail should not come out. That should be kept. And nowadays I use bone wax. At the end of the surgery, I just apply little bone wax over this, so that bone ingrowth will not happen at the end of the nail, and the nail extraction at a later date will be very, very easy for me. Friends, shoulder problems are enumerated. The main reason is too proud nail, which is the one which should be avoided. So after having done a surgery, you should encourage the patient to do passively movement within the next 24 hours. The patient is here, the patient is using a shoulder ladder technique to climb and do the abduction. After 10 days, just before the patient is discharged, you can see that before the stitches were removed, you can see that the patient is able to abduct actively. Again, this patient, you can see the incision passively with the help of other hand is lifting the operated limb. When he came for stitch removal, you can see the stitches are not yet removed. When he came for stitch removal, he is able to abduct it actively. So that is very, very important. Friends, regarding the radial nerve palsy, this is from the book AO Principles of Fracture Management. When patients present initially with a radial nerve deficit and a closed injury of the humerus, it is almost always a neuropraxia, and primary exploration of the nerve is not absolutely indicated. Over 95%, I reiterate, over 95% of the radial nerve injuries will recover spontaneously. So there is no necessity to go search for the nerve, see whether it is contused or not. You just can go ahead and do the nailing. Friends, but in case of secondary nerve palsy, then after you have done the surgery, patient had no nerve palsy earlier. If there is a palsy, then definitely it is something associated with a problem. You have to open and see the nerve. So this is very, very important. I might have treated at least in the last 20-25 years, about 15 to 20 radial nerve pulses which were pre-operatively there. I have never had the problem. All of them have recovered in my cases. Practically speaking, if one does close procedure, there is no need to explore except to explain the patient the possibility of the recovery in time. You can tell them that it is going to take 3 weeks to 3 months time. We'll do the nerve conduction test. If it doesn't recover, then we can explore at a later date. Like that, you have to keep them informed and give a reassurance. If there is a requirement to do a open reduction and fix, even when there is no need to specifically look for the nerve. However, if the approach is such that one has to tackle the nerve, as in posterior approach, the nerve is identified and a neurolysis can be done and continuity of the nerve can be documented. But this does not in any way hasten the nerve recovery. This is what the textbook, AO textbook say. So this is one such case which I had operated in 1996, almost 25 years back. This patient had a segmental fracture. This is after the initial surgery. You can see the radial nerve splint we have given in the patient. When the patient came at 4 months, the patient had a total recovery of the radial nerve. This is another case. Again, you can see the patient was traveling on a motorcycle and the sari, that is the dress material, get caught in the wheel and she was thrown off and there was a fracture of the humerus as well as radial nerve palsy. Again, I did the nailing and I have done the implant removal, as I said, and this is the clinical picture showing good radial nerve recovery. Friends, nailing doesn't tolerate gap at the fracture site. Unfortunately, humerus is a non-weight bearing bone. Unlike the lower limb bones, this distract the weight of the arm itself, distract the fracture site. So never ever get fracture site distraction. So this will act as a non-union machine. So gap at the fracture site. If there is a gap at the fracture site, how long to wait? This is a question. In a transverse fracture, persistent gap, non-weight bearing takes unusually long time if there is no problem. Allow all activity, it usually unites by 1 year. Friends, I'm telling this, interlocking nailing with a gap, normally it takes 1 year to show the union. Keep the patient informed to avoid apprehension. Otherwise, the patient will go to other doctor and somebody will do a bone grafting and take the credit for that thing. So you have to inform your thought process. This patient with so much of gap, you can see after 1 year, there was total consolidation without any intervention. Patient had no problem in between. The patient also had not come for follow-up in between to me. Probably if the patient had come in between, I would have taken a decision to do a bone grafting, but luckily he had no problem. So he came with a united one. This is an orthopedic surgeon. That was the time I was not doing even distal locking. I wanted to do all dynamic locking. I used to do only locking at one end. And I inserted a very thick 8 millimeter nail in that narrow medullary canal. Almost for 2 years, there was no fracture, didn't show any union. The person, orthopedic surgeon himself, he was doing all activity, including reaming with hand reaming using Kunsher reamers, and he never, after 1.5 years, he stopped taking X-rays. And then I went behind him, asked him to get an X-ray, and after 10 years, he took an X-ray in 2013. You can see that the fracture had consolidated. So the fracture which had not healed for almost 1.5 years, over the time has healed. So seeing a X-ray union sometime in a nailing will be difficult. This is the same person, Dr. Ashok Poddar, on whom on the right arm I have operated. That's the same case I was talking. This is the X-ray of Dr. Ashok Poddar after 10 years after nailing. We didn't show union for the initial 1.5 years, showed union at a later date. So the lessons learned are, in transverse fractures, it takes unusually long time to unite, as the bone is not a weight-bearing bone. Wait if there are no symptoms, inform your thought process to the patient, reassure them, and so that they will wait along with you. Otherwise, they will go to somebody and get it operated. As I said earlier, before doing humerus nailing, I was doing laminar wiring. I have good series of laminar united, and many of them were not uniting also. They have seen many of them non-union. So when Elizarov came to picture, I started putting a frame above and below. In the proximal fragment, one frame, and a distal fragment, one frame, and I used to compress and got the union. Similarly, few of the non-union cases of humerus also, I have taken the same step, and I have done with one ring with two wires above and below. I have compressed the fracture. This will give stability. It will give compression. It will also act as interlocking because the wires are there. It will prevent rotation. All this has given me good union. Unfortunately, almost 7-8 cases I had done. All of the pictures, images I lost due to a virus in my laptop at the time. So this was a case of non-union. Already 3 times operated by so many other surgeons. I was invited to operate this patient. I did a nailing. Again, you can see I used a Elizero frame above and below to compress the fracture. The fracture, which had not healed for almost 4 years, united after this surgery of mine. Friends, complications. Definitely plating, well done plating complications are less compared to nailing, but they're not, the difference is not too much, because almost 10% of the cases, if they have got some minor complication, that is acceptable. To give an example, plate failure patient is like a heart attack. If a plate fails, the patient is incapacitated. The patient becomes disabled. They come and get the surgery done immediately. Whereas if the nail fails, the fracture, there is non-union, there is gap here, but patient can carry on all the day-to-day activity, so they postpone the surgery. It's like a osteoarthritis of the knee. When we advise TKR, HTO, they keep on postponing. Similarly, with a nail, the patient postpones the surgery. Here, this patient came only because there was a distal end fracture. But this patient, almost 10 years back, the nailing was done. There was a non-union. Patient had no problem in spite of the nail being so proud. So this is Dr. Muki's case, which he recently shared on WhatsApp. So friends, what I'm telling is, with a nail in situ, patient is not incapacitated. The patient is able to carry out day-to-day activity. So they keep on moving from one surgeon to other surgeon. They keep on taking second opinion, third opinion, nth opinion. That's why we feel that probably nailing has more complication than plating. There is nothing more. Plating is 5%, 4% complication, and nailing is 7% complication. This was not a properly done plating, and the plate failed. Phylos was used, again that failed. This was the time I came to the picture, even that phylos had broken and the screws had broken. So what I did a humerus nailing, augmentation plate, and bone grafting. So absolute stability, non-union requires absolute stability, which I gave by a augmentation plating. The left side is 4 months picture and the right side is 9 months picture. Beautiful consolidation happened without any problem. The fracture, which had not healed by 3 earlier surgeries, could be united with a nail. I don't advocate this as a method of the treatment, but it can be treated properly. Nailing should not be blamed for all the non-union. See, this is a very improperly done nailing. There is a thin nail, interlocking hole is at the fracture side, short nail which is not going to the distal fragment, proud nail, missed proximal fragment. This is going to bend, break. So you should not blame the interlocking for this. You have to blame the surgeon for having done this a substandard nailing. So I treated this patient with a thicker nail, ream thicker nail, and this is subsequent follow-up. At 2.5 years when the patient came, you can see that beautifully the fracture had consolidated without any problem. So what I'm telling is, properly done nailing is more important. This is another interesting case. I want Sergio to be attentive. See, this patient was treated with an interlocking nail, such a proud nail. Patient had a lot of problem with the nail. So the surgeon decided to remove the nail. And this patient came after 1 year after the removal of the nail with a non-union. Pakka non-union, there was gap, there was a frank mobility at the fracture site. So this case, I treated with a plating and bone grafting. So as I said earlier, I'm not saying that I do only nailing. I also do plating. Within 3 months, the fracture consolidated. And see the clinical picture of the same patient, the entry site of the nail, you can see, which was so proud earlier. And these are the function of the patient after the fracture consolidated. See, Sergio, the shoulder abduction on the right side is practically full. There is no problem. In spite of the nail which was so proud initially, the nail was removed only because too proud and it was giving trouble. So don't blame the nail for the shoulder problem. Many of the elderly people will have shoulder problem. They don't do active physiotherapy in the post-operative period. That could lead to stiffness, or it could be due to the initial injury itself. See, this was a case of plating done elsewhere. The patient came to me for stitch removal and further follow-up. So this patient also has a stiffness of the shoulder. It could be due to the injury itself. So don't blame nail only for shoulder stiffness. This is what I want to tell. Another case of a humerus fracture, plating done. This patient came to me with a shoulder problem, young adult. I cannot say this is a degenerative cuff tear also. Young adult, it has to be the initial injury. When the bone has to break, it has to have some problem with the joint also. So never blame only nailing for the shoulder stiffness. Friends, removal is also very, very important. Just doing nailing is not that. This patient also had a crush injury of the hand, and this patient, after the nailing, only came after 2 years. He has never come to me for follow-up. So comfortable he was. So this crush injury I have treated with a external fixator. At 2 years when the patient came, he had a good function. See the incisions. He had multiple abrasions. You can see multiple CLWs which are sutured. So I couldn't have done plating in this case, definitely. Nailing I could do. Implant removal. Implant removal always again under CM. As I said earlier, I normally apply bone wax at the tip of the nail so that bone overgrowth will not happen. So when the patient comes for implant removal, getting that nail, entering into the nail by the conical bolt is very, very easy. A small incision is taken. Again, owl is passed. Because there is no bone growth over the end of the nail, the owl could be passed easily. Then I am passing the conical bolt. Once the conical bolt is passed, you can see that the conical bolt is not in line with the, you have to take picture in both AP and lateral picture. Once it is in line with the nail, then only tighten it. Then you extract the distal locking and proximal locking. Then you extract the nail again. So this is after the extraction. See the incision. So with a small incision, you can extract, provided if you use CM judiciously. The distal locking, the screw had already come out, so I had to take this out. This is at the end of the, again, after the implant removal also, start the shoulder function as early as possible. And this is at the end. Lastly, extreme nailing, because I know my friend Sergio is going to show some cases, very distal fracture like this. So I also do extreme nailing in the very distal third. As long as 1 inch space is available, I'm comfortable. If 1 inch space is not available, only a few centimeters are available and I'm not happy, what I'm going to do? This is a hybrid fixation I do. I don't advocate this as a general treatment. In the last 20 years, I might have done less than 10 cases only, just because external fixator along with internal fixator, there is high chances of pin track infection. So you have to take this not as a standard treatment. So this young engineering student wanted to attend the exam and the lab. So I used the external fixator as the interlocking hole were too distal and I was not, probably I couldn't have done the locking properly. Proximally through the jig only, I inserted through the hole in the nail, through the jig, I inserted the shank pin. This is after the fracture has consolidated, the patient had a beautiful outcome. What I normally do is another case. I normally insert a cap of the vial so that the spin and the shank pin movements will be stopped. That movement is the one which causes the infection. So proper skin care, pin track care should be taken. This again, this young boy, because of the combination, I thought let me do a external fixator as a hybrid fixation. This is after the implants have been removed. Unfortunately, though clinically it was not very significant, you can see there is a varus happening at the fracture site, because in this problem is due to the nail enters the lateral condyle easily. So nowadays what I do is when I take this case, I see that I open up the olecranon fossa and push the nail in through the olecranon fossa, as you can see in this case. So the nail is passed through the olecranon fossa after opening up the fossa. So here you can see my guide wire is going to the lateral cortex. What I did was I used a straight trimmer, opened up the supracondylar olecranon fossa from the top. Then I passed a guide wire. Then I did the reaming. You can see it's in the center of the distal fragment. Then I have passed the nail, and then I have applied the external fixator. So once you know the problem you are facing, you have to analyze your own problem. Then only you can get over that. So these are some of the subsequent pictures in the same patient. Such a distal third fracture with so much of combination, I could get beautiful result in this patient. This patient, I couldn't get the clinical pictures, but I got his pictures of the implant removal. This is the proximal locking done with a shank spin. So there is no other incision. From the top, I have opened up and gradually I have taken out the canal. With a small incision, I was able to do just removal of the nail when he came, because fixator was removed at the end of 6 weeks itself. Friends, to conclude, humerus nailing is a very good method of treatment. Keyhole surgery is possible, not as bad as depicted in the literature. Complications are slightly higher when compared to a plating, and it does not tolerate gap. That has to be taken care. Do it properly. You will never ever, you will not be happy with, by doing properly. So it will never disappoint you. Thank you very much. Thank you, Dr. Sergio. If there are any questions now, I'm ready to take now.
So, Shiva, first of all, thank you a lot. It's beautiful to see a guy with a lot of experience. I would like to mention some topics before we discuss a little. I'm going to change a little bit the dynamics because Dr. Coco, he has a fracture to operate, but he's going to discuss a little bit of his cases before he leaves. We can do it, and then we listen to Dr. Belangero and I talk in the end. But the thing is, the first thing I want to mention before we talk a little is that the surgeon is the method. I learned that with Gilles Vauch. Gilles Vauch, the surgeon is the method. So when you master something, you can do a lot of, you can use it in a lot of different scenarios. The only issue that I keep on always on thinking when you, Shiva, shows this beautiful lecture that I have seen sometimes, and you always make it bigger and better, is the issues about removal of the implant in a blind way. So this is what really concerns me. I would like us to talk a little bit about it before Dr. Coco speaks. But Dr. Coco and Dr. Belangero, but especially Coco, because you have a lot of experience with nailing, and besides the issues on removal, any specific thing that you would like to mention about this beautiful lecture of Dr. Shiva, Dr. Coco?
Oh, can you hear me?
Yeah.
Yes.
All right. So it's a very good talk. And in my hands, I'm a big fan from humeral nail. I used to fix my fractures with this technique, and I have really good results. So it's a kind of situation that we can choose between nailing or not. But in the distal part of the humerus fracture, I really use plates. I mean,
okay.
How distal fracture, in my mind, plates are better results and easy to fix than in the middle shaft. So I don't want to change my mind to have to nail all fractures. I mean, okay. I can do both, and I prefer nailing, but this is not a situation that I have to nail in all the fractures.
Yes. No, you see, there are many ways to skin a cat, and one of the beauties of this topic is that we have different ways to get to a final good result. Dr. Belangero, he knows that, but still, well, I would like to talk a little bit about the rotator cuff. We could stay 2 hours only discussing this, but we don't have that time. But Dr. Belangero, I'm really interested in your thoughts, at least the most important things about Dr. Shiva's lecture, keeping in mind that we have hundreds, maybe thousands of young surgeons listening to us. I would love to hear you, sir.
Okay. Congratulations, Dr. Shiva, for your nice presentation. Very good cases. I think that you have surgeons that like more nail and surgeons that like more plating. No?
Sure.
This is an option for the surgeon sometimes. But you have some kind of fractures that you can put nail or plate. For example, mid-shaft fracture, humeral mid-shaft fracture, you can use nail or plate. I think that in the most proximal fractures, in humeral most proximal fractures, nailing has a little bit advantage for plating. No? But for the distal fracture, I think plate is best.
Okay.
In my opinion, no, I don't have experience with nailing because I use plating for all fractures that I've been treated, but I see in the literature that nail is coming, and the result when you compare nail with plate is almost the same. No, you have the same rate of consolidation. Infection, it's almost the same. I think it's a very good option.
Yes.
Okay, lovely. And Dr. Coco, you know, as I am a shoulder surgeon who does a lot of shoulder and elbow trauma, I'm always thinking about rotator cuff. So, and Shiva knows that. So having said that, let me say what you, Coco, says about what you say about removal of the implant. This is something that, you know, I am always, I would say, shocked in the very positive way how Dr. Shiva takes the nail and he doesn't seize the cuff and the patients do absolutely fine. So this is something that I think, Shiva, that you do it in a very high level, and maybe that would not be, I would say, allow me to say this, advocated for all of the juniors to take the nail out without seeing the cuff, without your experience, because we know that rotator cuff is a fragile structure. So having said that, Dr. Shiva and Dr. Coco, any thoughts about strategies not to damage the cuff in removal? This is a key point, and I think it must be addressed, and Dr. Belangero is agreeing with me. So Shiva and Dr. Coco, your points about this exactly issue, which is very important.
See, in the shoulder, the fibers are in this line. So when I insert the K-wire, I take a small incision in line with the fibers and split open. I'm not taking the incision at 90 degrees to them. So I take the incision in line with the fibers. So I open up with the artery forceps. Probably that is one which is not damaging the rotator cuff. That's one.
Okay.
Second thing is my incision is always 8 millimeter or less. If you see on an arthroscopy, there is a 8 millimeter rent. Do you stitch it? This is my question as an arthroscopy surgeon, shoulder surgeon. So you will also think that it will overlap and heal them properly. So
yes,
a small incision over the rotator cuff is not going to do any damage. But most important thing I feel is doing the active exercises with the normal hand. They keep moving it, and almost always my anesthetist gives supraclavicular or cervical nerve block. So the patient will be pain-free almost for 24 to 48 hours. I get all the shoulder movements done in the post-operative period. So that could be the reason. Yeah.
Okay. Okay. Coco, your thoughts about removal. This is a key question.
All right. So I think to remove the nail sometimes is harder than put the nail.
Yeah.
So I think the pitfall is preserve the rotator cuff insertion. The tendons are the problem, not the muscle. So that's making the entry point have to be in the center of the head, not in the great tuberosity. So the medial aspects of the rotator cuff is safe enough. You know, my master degree was evaluating what happened with people with antegrade nailing. So we have good results when the muscle are treated like a muscle and the tendon the tendons have to be treated like tendon. So when you have the rotator cuff lesion, you have to stitch the tendons, not the muscle. So if you have a big hole, in my mind, you have to have a big incision and see what's going on in the rotator cuff. And if you have a good stitch, I mean, if you close the rotator cuff, we preserve the soft tissue and the bone. So my incision to put the nail and to remove the nail is more than 8 millimeters. So I really like to see what's going on in the subacromial aspects of the shoulder.
Yes.
So makes me comfortable to really
I think like that. So what is the size
motion?
Yes. So what's the size of your incision when you take the nail out? I just want to know, is 4 centimeters, 5 centimeters?
Yeah, between 3 and 5 centimeters.
Okay.
It's like that.
Yeah. And you see the cuff, Dr. Coco.
And I touch the cuff. I can put my finger and be 100% sure there is no hole after put or remove the nail. Okay.
So having said that, because this is we have been discussing this for a lot of time and many years, but it's beautiful to show these different point of views in this topic. Diego, any clues about these nailing issues?
Yes, I think it was an amazing lecture. I want to congratulate Dr. Shiva. It's a huge experience he has. And a thing I want to say, as well as Coco said, is the entry point. I think that's fundamental. And that's maybe my main concern nowadays when I use a nail. I think the techniques have changed a little bit. And we even have less damage if we use the center of the head as an entry point. And we can be as medial as possible to avoid having shoulder injuries after the surgery.
Okay.
I agree with that part. Even I am taking more medial entry nowadays from the top. Yeah.
Right.
Okay. So my last question, Shiva, with all of these concerns about entering in the middle of the head, I like it what Dr. Coco said. You think about a muscle as a muscle and a tendon as a tendon. It's not a cliche. It's a reality, okay? Not cliche, it's a big reality. So having said that, have you been changing your mind, Shiva, to enter more medial or not?
For proximal humeral fractures, I started taking the entry much more medially. Then I realized that the entry in line with the medullary canal makes our life much more easier because the nail can easily go. So nowadays, even for shaft fractures, I don't mind taking the entry from the center of the head.
Okay.
Yeah.
So see, just one thing. As Dr. Coco, he has a big fracture and he has to leave in 25 minutes. I'm just gonna change stuff for him to show us at least 1 or 2 cases before he leaves. And then we can go with Dr. Belangero. Just very fastly, Dr. Belangero, as you were mentioning that you like nails, especially when you go, I would say, more proximal. Any points about the entry point of the nail, Dr. Belangero? Anything to add about this? Because many people want to listen to you.
Yes, I'm referring about these new nails. I think the new nail, it's a straight nail. Then the entry point is in the center of the head.
Okay.
Not in the cuff, in the muscle. I like this nail. I don't like the other one. I like this one, this modern nail. I think this is a good nail. Okay.
And this is an important message for the nailers to I would say to properly do the entry point. This is something very important because, as I always say, whenever you put a synthesis, remember that one day you might have to remove it. So we have to think about removal in any part of the human body when we are doing something. I think this is very important. So Coco, can you share your screen, at least 1 case, maybe 2, before you go to your fracture and we stay with the rest of us?
All right.
Okay.
So Are you following me?
Yes.
Yes.
Ready? Hold on.
Yes, you can go.
All right. So first of all, I want to really say thank you for all this team, especially to Dr. Sergio Rovinski, a huge friend, and definitely you have done an amazing job here in Brazil, sharing all your experience, and of course, invite people to understand how we treat some kinds of fractures, and definitely learning with people like Dr. Shiba, the experience around the world. So thank you for inviting me to join this beautiful group.
Sure.
So the first case is a motorcycle accident. It's a male, 26 years old, with this kind of fracture. So I want to break the protocol a little and start asking Dr. Diego Gomes, what do you see here? How does it work in your hands?
Okay, thank you for the question, Coco. It is a difficult case, of course, and you have many fragments there and a very distal fracture as well. So, of course, my first concern when I see this X-ray is what about the neurovascular status? It's not a small thing.
No radial palsy. That's just, actually, there is just a little trap in this case, because this is not the fracture, only the fracture. The patient has an open fracture in the tibia. The shaft tibia was an open fracture. So this will be my next question. If you have this single fracture, or maybe you have both fractures, things about damage control or early total care. Let's start thinking about just this fracture. This is isolated fracture.
Okay, let's think only about this one. So if you have this huge fracture alone, isolated in one patient, I think in our hands, in our hospital, we'll do a fast treatment of this, maybe the first day, if it's possible. And of course, this is not the patient for a nail, or at least in my hands, I would go with a plate. And having said that,
I could see Dr. Shiva say, "Hey, I can nail this fracture."
No.
Is that true?
Yes. So I'll plate this with the anterior bridge plate. I think the AP, whatever you are seeing the picture, is a end-down view of the flexed fragment. But in the lateral, we can see that there is some place for at least to put 1 or 2 screws. So definitely, it will be a case for Sergio to handle this with the anterior bridge plate.
I wanna say 2 important things. Okay, first of all, the morphology of the fracture is not being fully comprehended in this image. We know that traction views, they help a lot, but it's very difficult. So in this sense, and I have experience in this point, a 3D CT of the whole bone would give us a lot of information. And I have faced similar cases. This is one point. I would ask, and I have in 5 minutes in my public hospital, a 3D CT, which gives us a lot of information to know if I can do a bridge plate or not, because we are not having a good comprehension of the distal fragment. Another point is that bony instability means soft tissue damage, in a way that maybe one thing that could be done for damage control, we are in the middle of the night, we have only residents, is with a lot of common sense to do a transient X-fix only in the proximal ulna, very gently, only in the proximal fragment, just to stabilize the bone as a damage control situation. And you know, the behavior of the soft tissues is extremely different when you do damage control. So that would be something, because in this case, the distal fragment is the key. Yeah. And having said that, as we have this new one, I would do exactly the same. An X-fix in the tibia, in the arm, in the way I said, damage control, and then we would think about definitive synthesis in the sequence with a 3D CT in that humeral fracture.
I swear, this is the only inferior limb X-ray that I have in this meeting. I know that people want to see humerus fractures, but in that situation, when you have a humerus fracture and we have a polytrauma patient, sometimes you have to think about treat the patient, not the fracture. I mean,
yes.
So we have this open fracture. And Dr. Belangero, do you agree or have anything to say about how to treat this patient? Instead of fixation, or you are able to fix all this fracture in the same procedure?
Coco, this is a very interesting case because this is the patient is a polytrauma patient, as you said, and we need to evaluate the patient clinical condition. And if you have a good condition, clinical condition, maybe you can fix the fractures. But I think the better is to make a damage control in this case, use an external fixator in the both fractures. I think it's because yes, this is my idea. And I'd like to make it, to pose a question for you. I'd like to see the length of the distal fragment, the humeral distal fragment, because this is the key to define the treatment. This is very important because usually this fragment is flexed, or you can see exactly the length of the distal fragment. Yes, you see the fragment on top. It's not the correct length. This is a very important image that you need. Another point for the young guys that are seeing this presentation, this is a very good example to treat by biological concept. This is a fracture that you need to use biological concept to treat humeral shaft fracture in this condition. I think this is a very good example.
All right. So absolutely right.
Coco,
all right.
No, just a second. I said exactly that we should evaluate the size of the distal fragment, and a CT, a 3D CT can be a tool for us to see that. But what Dr. Belangero said is very important for the young surgeons to understand. I would say the biceps and the triceps, they displace that very tiny fragment in a way that you cannot see the proper size of it. So what Dr. Belangero said is a key point, and we really have to understand it. And now please continue with the history,
Definitely, I agree with all talks that you had, because we decide to preserve the soft tissues. Doesn't matter. We have time now to think about what to do, because we have stabilized the fracture and we preserve the soft tissues. So we can think about where to use the shants, the pins, preserving the distal fragment that we know it's short. And I don't want to put a shants in a small fragment. So that's the point that we decide to use the forearm and the humerus, the proximal part, and preserve the combination and the distal fragment. So when you do things like these, we have to check before and later what's going on with the radial nerve and still working. So we decide for damage control. And now what to do? Of course, the tibial is not a big deal. We can nailing this fracture, and with a gold standard option, right? Remit and nailing, it's done. He's able to walk in the next day. But how to fix this fracture? So, Dr. Diego, in your hands, in Argentina, how to fix this fracture? In the
tibial fracture, you mean? Sorry.
That situation. So you have all the stuff that you need. You have nail, you have plates, we have wires, you have casts. How to fix that, my friend?
Again, I would agree with.
We can hear you. Open your microphone.
It is open. Can't you hear me?
No, it's open. It's open. It's
Yes.
open.
Oh, it's working.
Okay.
I can hear you.
No, but
I don't
no,
know.
we are listening. No, I'm listening to you.
Oh, go ahead. Go ahead. Go
You
ahead.
go
Okay.
ahead.
So again, I would agree with the importance of measuring and understanding the distal humerus fracture. It could be with a CT scan, it could be with better X-rays, but it's important to choose a good treatment. And this kind of fracture, as I said, if it's isolated, I would think a little less in damage control. If it is in a polytrauma patient, of course, what you have done is it's perfect, it's beautiful. And I would treat it with plates, and it depends a lot the type of plates on the distal involvement. Because of course, if you have a really short or maybe an intraarticular fracture, you may want to use distal plating, anatomical plating fractures extended, they're really long ones. But if you have a considerable size distal fracture, you may use LCP plates, or you can use any locking plates straight that I think with Belanger's technique you can handle it.
Okay, just a short answer because I have no time.
Sorry, I could go with plates.
Both fractures at the same time. Treat the tibial fracture and the humerus fracture in the same situation in the same time, or just fix one and another one in another surgery? What do you support?
Well, for us, we are in different teams here. Okay, so I don't do tibia. So in these patients, usually we don't do it at the same time. We do one and then we do the other. It's too much for the patient many times, but if you can do it, I would start with the most difficult fracture, the most unstable fracture, the most difficult for the patient, I would say. In this case, I think you have much more experience in determining which one it is, but I would like to start with the tibia, I think, and then the humerus, I think, in my practice.
Dr. Coco, please, do you have post-op X-rays of the X-fix? This is a key question.
No, I don't. No, I don't.
Okay.
But Dr. Belangero, both at the same times, bridge plates.
Coco, I think it's okay to do both at the same time. Yeah. And for the humerus fracture, I try to do a biological treatment, a MIPO technique. I'd like to see the size of the distal bone fragment, but you don't have. Okay.
But what changed your mind? Okay, definitely it's better to see, of course, but what could you change if you have a small fragment?
If you have a small fragment, if I think that even in this situation, you can do anterior bridge plate using the lateral column, the distal lateral column of the humerus. Then you can put 2 screws at least in the distal fragment. Then you extend the plate, but to do this, you need to make a twist in plate, and more 20 degrees, twist the plate and mold the distal part of the plate. This is another option. No, I like it very much, this option. Yes, this is one option. This is posterior approach. Right. Yes, I know this technique. This was described from a colleague from Argentina. This is another possibility. Yes.
Patient is facing down. We have 2 incisions. In the proximal aspect, we can see the triceps head and the distal, the triceps tendon. We open lateral and medial. That's the picture with the ulnar nerve isolated. And we decide to have 2 plates. So here you can see the radial nerve. And we have two plates, like you said, we twist the plate, the medial plate is twist, to have the approach in the proximal aspects of the humerus. So we are able to fix, to put the screws just posterior anterior view. I mean, we don't need to find the medial aspects of the humerus to use the screws. So we twist the plate and we decide for biological fixation. Dr. Shiva, what do you think? It will work or not?
Yes, definitely it will work enough. This is a biological way you have preserved as much as possible the biology. And I'm happy with this, but my friend Sergio would have definitely done an anterior bridge plate. This fragment is big enough. I can see in the left side picture, the first picture, that the fragment is good enough to hold 2 screws.
Yes.
Yes. So,
So-
definitely, yeah.
Dr. Belangero, when you have a supracondylar humeral fracture, definitely we use double plates, right? To fix supracondylar
Yes.
humerus fracture. Is this
Yes.
a kind of shaft fracture going down or a supracondylar humerus fracture going up? What do you think?
It's a good question.
Very good.
I think this is a shaft fracture going down.
Going
Yes.
down.
Yes.
So,
I just want to mention one thing, Coco. Just one thing very serious. There is space for 2 screws down, and I'm gonna show. Unfortunately, you are not gonna see because you have to leave. I'm gonna show in this webinar one case more distal than this one with outstanding final results. Okay, so if I saw a sitting, I would. So I can do an anterior bridge plate here because there is
if you
space
have,
for
this is not a locking plate, right? This is a regular one. But if you have locking plates to fix this fracture, do you think it's mandatory with a 26 years old with this kind of bone?
No, and this is another discussion.
No locking plates.
No. This is another point that I would and I will address with Dr. Belangero, which is the $10 million question. Anterior bridge plating with locket screws or with DCP screws. This discussion started in my life 15 years ago. Still a discussion. In my mind, the problem is solved, and I'm going to show in my presentation only DCP screws. So the $1 million question is 2 or 3 screws, and the $10 million question is DCP screws or locket screws. I only use, and my friends, only DCP screws, and so far so good. So the thing is, coming back, if I would have seen the fragment with a 3 DCT or with post X-rays
After the surgery,
and I would do
after the surgery,
immediately.
radial nerve still working.
Yes.
So
Very nice.
10 months.
Very good.
With 10 months.
Mhm.
Lovely. Good.
Dr. Sergio, look this detail with the right shoulder. What's going on here? The internal rotation. What's going on here? Why this guy have to move like that? What's going on here?
Probably there is no place on either side. That's why he's taking it anteriorly. There is something on the side of the patient, or there is wall I can see on the left hand side.
I'm not exactly understanding your question. I'm sorry. I'm not exactly.
To finish the internal rotation, the patient have to put the shoulder a little bit forward to finish the internal rotation. In my mind, what happened here, probably we fix in the right axial
Oh, yes.
alignment,
Yeah.
but a little bit rotation.
Mm-hmm.
Yeah.
Right?
What I
The
think.
distal aspect of humor is not
Easy
exactly
to identify. Yeah.
right.
Coco,
but it's working.
In the posterior approach, it's not easy to correct
Control.
or to identify rotational deviation. It's not
Correct.
easy.
But a wonderful result anyway. Very good.
Yeah, very nice.
Actually, we noticed only after he said that those points. Otherwise, we couldn't make out that point also, that there is a problem with the rotation.
Yeah.
So
Excellent. Yeah.
tibia heel and the humerus heel and the patient is really good. No,
Yes.
no big deal. Works.
And happy.
Finally.
Lovely.
So,
Everyone's happy.
Yes.
again, I want to break a little bit the protocol and say how it's good share this situation with you guys and especially with Dr. William Belangero. He's our father in thinking about biological ways to fix this kind of fracture. So it's a pleasure to me share experience like this. He knows that I'm really nailing guy, but I don't think that like Dr. Shiva said, I don't think that I have to say bad words for plating to say that I prefer nailing. So with both, we can fix thousands of fractures, and the treat is identify the right patient with the right fracture, with the right surgeons, with the right skills to fix the fracture. So you can have good results with both situations. To finish, oh my God. So another motorcycle accident with male 30 years old with not high energy fracture, things like we have in all ER hospitals. We have a fracture like this, simple fracture in the shaft. Who treat this? The first option is operating techniques, or who of you guys decide for no surgical treatment? Raise your hands who decide for no surgical treatment.
This is a isolated fracture, Coco?
Yes, it is.
Okay.
Coco,
no chance for no operative treatment?
No. No, I would fix it because they are very, very unstable fractures and very difficult to manage from a non-operative point of view. Yeah, it's very difficult to manage this non-operatively. I know, I suffered a lot. I would do an anterior bridge plating immediately. This is a consensus.
Why not open reduction and tendon fixation with the plate? I suppose that many people will decide for open reduction and internal fixation because this is a single fracture. You are able to compress the fracture. The traction using a regular plate, we strong enough to fix this fracture. Why did you decide for anterior bridge plate?
The less invasive, the better. So a lot of people have been asking me, what about transverse cases? And I'm gonna show 2 transverse cases in my presentation, both healed beautifully in a way that, in my point of view, anterior bridge plating is much less invasive than an open standard technique. And this is another consensus in my team. So even my residents, they know that this is gonna be an ABP, an anterior bridge plating for Sergio's team. We are very established over there. There are other guys now after many years who know how to do it. And unquestionably, in my hospital, anterior bridge plating, and thinking that transverse fractures doesn't heal on anterior bridge plating is a fallacy, is a myth. And I can show you a bunch of cases, but I'm going to show 2.
Yes, I agree completely. I have many cases like this. That I use the MIPO plate. But I like to treat this fracture by conservative method. Yes, I like to treat this. This is not difficult to treat.
Okay.
And for isolated fracture, I start every time with a conservative method.
Okay.
Or if the patient asks me to treat the fracture surgically, okay, it's okay, I go on. But if not, I start with a conservative method.
Okay.
All right.
Even in this kind of case.
Okay. Okay. Coco, to answer your first question, when you said that whether you are operating or not operating, yes, I'm going to operate. There are two reasons. Sergio, there are two reasons. One is I am a private practitioner. If I am not operating, he will go to somebody else and get operated. So second thing is he's an adult.
That's a really good answer.
Yeah. The second thing is more important thing is the academic answer is he's an adult. Let him not be bothered by the cast for 1 month, 2 months, then talking about it is difficult to convince the relatives when there is angulation like this. The relatives come and ask you so many questions. So it's really bothersome to answer them. So it's better to do the surgery properly in the initial stage itself. That's one.
Besides that,
yes.
So, and just one thing, I have a lot of experience because we have an OPD in my hospital only for conservative management of all the fractures for the residents. So what I can tell you, I can guarantee to you, the first month of management of these cases for the patient is painful, is hardworking, and you must have them every week doing next x-rays to control deviation, to control displacement. And if you do an anterior bridge plating, as long as the patient doesn't fall from a motorbike on the next day, everything's going to be okay. I've been doing this for 15 years. So you see, you have to have the patient on your hand for 6 weeks. And I saw a lot of complications, non-unions, symptomatic malunions. This is, in my opinion, the worst case to be managed non-operatively. And listen to me, if the patient is obese, then you have double the problem. In a very hefty arm, this is very difficult.
Yeah.
So we have 2 months and a half. And like Dr. Sergio says, it's different, especially in a resident hospital. When I decide to treat with no surgery approach, I decide for that, but someone will follow the patient, and the next week another one and another one. So that this is not a no option treatment, right? If I decide for no option treatment, I have to follow the patient for all the treatment
until the end.
I know what. So when I have 2 months and a half with that X-ray, but the patient say, no, it's not a big deal. I'm going better and better. What to do, Dr. Belangero?
Follow the patient, but you need to follow the patient carefully, not lose the patient. Follow the patient carefully.
Yes,
this is very important. You need to see the patient every week.
Sure. And Coco, we have to think about something, okay? This is what I learned in United States. There are 2 phrases that define the behavior of the doctor, explained by Dr. Belangero. The first one is wait and watch. Wait and watch. And the second one is beautiful. I learned it with Shiva, which is masterful inactivity. Masterful inactivity. So you are not doing activities in terms of surgical intervention as a surgeon, but you are watching this patient all of the time. So I fully agree with Dr. Belangero. Wait, but watch. You cannot say, go. You have to keep this patient under your vision, under your umbrella all of the time until you see the final definition, which is probably gonna be bone healing with, I guess, acceptable varus. But let's see the end of the story now.
6 months, there is no union. I don't think now it will not unite. Yes.
Okay.
Yeah.
Diego, and what about now? What to do, Diego?
I wouldn't decide only with the X-ray. I think the patient symptoms at this time of the evolution, it's important, because if it's in the way of healing, he will tell you before the X-ray.
Sure. How is the patient from a clinical point of view, Coco?
He's able to move. It's not painful, but it's not stable. You can move the humerus. You know, this is a non-union, but the patient say, no, but it's not that bad. I don't want to fix. I want to. I
Wait and
can
watch.
walk.
So wait
Right.
and watch. And this is what you did. You waited and you watched.
So now it becomes a harder. So the non-union was a little bit stable enough for the range of motion for daily activities. But with a new accident, with a new motorcycle accident, he had a fracture. Not the no union was in the same place, but now he has a fracture. And we have two situations now. We have a non-union, we have a fracture. And Houston, no problem.
But
the first thought is the non-union was stable enough.
Yes.
Stable enough.
To have a fracture, the non-union is very stable.
Yes,
Right,
it is.
right.
At least in
Probably
both motorcycle
if
accidents. So
had
that's
no fractures
enough.
anymore, he would say, I don't want to come back to the doctor because I'm good enough to do my daily activities, you know?
But do you have bad X-rays now? This is a serious.
No, I have. It was a fracture around the proximal aspect of the non-union. I have these X-rays.
Okay.
Can you, Coco, go back the previous X-ray? Because here it looks, yeah, but since we don't have a proper AP,
Yes.
here
No.
it looks very mobile. It doesn't look to be stable enough that there can be a fracture next to this fracture. It's very difficult to digest unless this is
Yes.
cited subsequently or you have done something. Yeah. Anyway,
So keep watching.
keep watching. Again, you have applied the slap. Continue.
Coco, this is a very good indication for meeple plate, anterior bridge plate. You can treat both conditions.
All
You
right.
treat the
All right.
fracture, and then you treat the delayed union.
Dr. Sergio wanna put the patient face down, open the posterior aspect of the humerus. You wanna short the humerus and make a plate with thousands of screws.
No, to be very honest with you, with all respect, and I would never be disrespectful, I cannot take a decision with these images. Super serious. Because I would need to better understand what's going on. But see, you have a pseudoarthrosis, or much probably a pseudoarthrosis, a new fracture. Maybe I would think, but I would need better X-rays to do an open anterolateral approach, and I would say shorten the humerus, take the bad bone, the devitalized bone, compress a little, and put a plate. This is a very, for the juniors.
Like I said, Dr. Belangero understood me. Like I said, I know, Sergio. I know.
Okay, but the
He's
thing
able
is,
to open the humerus and use the screws like.
No, you know, the less invasive, the better. But you see, we are facing, Dr. Belangero knows, a very difficult situation. A fracture and a delayed fracture, or a fracture and a non-union in the same bone is not common, especially in the humerus. So we have to open our minds to deal with these uncommon scenarios.
Dr. Diego, what do you think about nailing this?
No, I'm not comfortable with nailing in these scenarios, not with close nailing at least. I mean, if you want to use a nail, you would need to open the fracture, and it's not a good idea. I would go with biological treatment.
Why you need to open? What's the hard thing to do with a close approach?
Of course, when I think about the impossibility or the difficulty of doing it close, I'm thinking about the non-union side. And you may even do it close, but it's dangerous and it's not sufficient to treat it, I think. But it wouldn't be my choice to do a nail here again.
Sure, not mine too.
Dr. Shiva, do you think it's an option nailing the shoulder arthrosis or non-union and the fracture and treat with just one implant?
Okay. At 1 month or 1.5 months, when you showed the X-ray, nailing was an option. When you could see some callus, it required only stabilization. But now there is non-union. If I have to do surgery, I have to be the last person. I cannot take a chance. I have to do the bone grafting. There is a non-union which requires absolute stability. So I'm not like Sergio, I will not throw up the middle fragment. Yes, I'll open up the non-union side. I'll put a intramedullary tricortical graft. I'll put an anterolateral plate. Additionally, medially and posteriorly, I'll put a lot of grafts so that it will unite. So,
But Shiva,
touch this patient. Now, if I want to touch this patient, I want everything to be done in one go so that I don't want to take a
fully
chance.
agree. Fully agree. But see, Shiva, I didn't mention that I would throw away the mid-shaft fragment. I need a better understanding. But Dr. Coco, he's a psychonailer, so let us see what he has done.
Glad to introduce Coco to me. We will have a lot of interaction in future.
It's a pleasure, my friend.
Yes.
So, first of all of us are orthopedic surgeons. And of course, some people are nowadays a little bit more shoulder surgeon than orthopedic or work with the trauma. But all of us, we have trauma in our heart, right? So we can bring with us some ideas for inferior limbs and put in the superior limbs. So this is a reamer that I used to use on a tibia fracture. It's a rigid one. So in my mind, the big deal here is not to ream the proximal fragment, but the distal fragment, because the shafts were closed with the non-union. So I use a rigid one to open the canal, right? And then I use the wire and ream all the shaft with ream it, and then I use the nail. So this is the immediately post-operatory X-ray. We use that time. We use just one screw on the distal aspect. Nowadays, like Dr. She said, I used to use 2 screws on the distal aspect of the humerus, and we had that. So who of you want a bet with fail, with works? Heal or not?
I am in the middle of the story.
I hope to heal. I hope to heal.
I hope too, because I have to leave. So that's it. I have to be good enough to leave.
The way Coco is taking the challenge means it has healed. That's why he's ready to take the challenge.
Yes.
2 weeks. 30 days. Let's open and maybe PRP or what to do. 30 days.
Wait
and watch.
Wait for the proximal fracture to heal at least.
Yeah. Okay. Nice.
1 month.
Yes.
So.
Excellent.
Very good. Very good.
And we started UFC and MMA. That's the man. He's able to resolve all the problems. And this is a kind of wave or wave. That's our paper that I told you guys. We had some experience with what happened with the rotator cuff after kneeling, after humeral nail. And we have a good results, but like we said before, we have to treat the rotator cuff with all respect. And some people say, when we have this talk in a shoulder congress, when we start to show the nail, we can see the audience. Some people start to cry. Some people start to say, "Oh, let's get out of here." And but why these people believe in femur nailing or tibia nailing? So what about the tendon, or even the rotators in the hip, why they are not so important? Why people think that you can open that and use, and what's the rotator cuff is not able to be treated with respect and able to be open and closed, and you have a good result. So that's our, we have this kind of research in the trauma department. So we believe the nailing is not a big deal, but sometimes the surgeon is the problem. It's not the nail.
Sure,
And
sure. It
so,
happens a lot of time.
Before Coco goes out, no, Coco, I would request you to try my technique of keyhole incision. So then you can, since you can work on large cases because you are working in a public hospital, then you can see the result for yourself, and you might come back after a few years, say that what you are opening the rotator cuff to see was wrong.
All right.
Yeah.
All right.
Good.
All right.
Good. That's the next step.
That made me think about.
Yes.
Made me think about.
Yes.
So anyway, I'm really late, and it was a pleasure talk to you. That's amazing team. Dr. Sergio, Dr. Shiva, Dr. Belangeiro, Dr. Diego, was a pleasure talk to you, and I hope to see you again.
Thank
Lovely.
you. Thank you.
Okay,
Yes.
Coco, thank you.
Coco, thank you.
Beautiful cases.
Beautiful
Thank
cases
you.
and beautiful solutions. So
Thank
now,
you very much.
Guys. I hope to see you soon, and take care. Stay
Okay,
at home.
Thank you so much, Coco. Good luck with the fracture. Bye-bye.
Okay.
Thank you. Bye-bye. See you.
Okay,
Bye-bye,
see
Coco.
you. So it was really an interesting case, very interesting cases. But now we have to go to the anterior bridge plating part, which is what touches my heart with a lot of strength. So Dr. Belangeiro, can you start your lecture?
Yes. Let me share my screen.
Okay.
It's okay?
You can go. You can go.
Okay. Okay. Good evening. First of all, I'd like to thank you for this opportunity to be here and in this fantastic event to learn and to share with everyone the experience I have with MIPO technique over 20 years. This is my disclosure. Let me see here. This is my disclosure. Okay, everyone knows Dr. Sergio from São Paulo, Brazil. I come from another city. The city called Campinas is located here. This is the view of Campinas, 100 kilometers from São Paulo. It's a big and beautiful city. You are invited to come here. And this is my university where I have been working at Unicamp, State University of Campinas. And this is the hospital that I've been working. Okay, let's talk about MIPO. We started our anatomical study on cadaveric specimens at the end of the 1999, and we noticed that in the anterior aspect of the arm, there was a region where vascular or nervous structures did not cross. We found a safe corridor, a safe anterior corridor that we can slide the plate. Using this approach, we treated 15 patients at the beginning, and then this anatomical and clinical research was used by my colleague, Bruno Livani, for your master thesis that was right in 2001 at the beginning. This is some images of the topographic anatomy of this region. You can see the plate, the relationship between the plate and the bundle, vascular nervous bundle. And you see here the relationship, the plate and the anterior aspect of the arm and the radial nerve. And you go down, you see the radial nerve, it's far away from the plate. You see here in another slice. Well, this was the thesis from Bruno Levant. This is my colleague, my friend. And this is the paper that we published in 2004, describing the technique and presenting these 15 patients. Okay, this is a simple fracture to present the current technique. I think that this procedure has several advantages, mainly for our countries because it's a simple, safe, reproducible, and it not a sophisticated or expensive instruments and implants, as you can see here. And I beside this, technique nowadays, I'm sure that the learning curve is very short. I have my preference to use DCP plates until today, but it's very difficult because nowadays we have LCP plates, and I use LCP plates using the majority of the cases cortical screws, not lock-in screws. Okay, let's start the procedure. This is a wood device that I use, covered. I used to support the patient's arm. It's allowing X-ray control and the surgeon and his team around the arm. The first important tip, the surgical approach in the center of the arm, please. Don't do it laterally or medially. Do it in the center. This is very important. I usually start with the distal one. This is the two windows that I use to slide the plate. I started in the distal one. No? Then you see here, this is the biceps. We identify the biceps, and then we displace the biceps medially. This is the bicep muscle. Then we find the musculocutaneous nerve here, and we split the brachialis in the center until to the bone to reach the bone surface, okay? This is an anatomic view. You can see here let me use the pointer laser. You can see here the brachialis is splitted. This is the plate, it's a cadaveric specimen. This is the musculocutaneous nerve, and the radial nerve is here. Okay. Then I go to the proximal approach. No? It's very easy approach. You see, between the pectoral and the deltoids. This is the pectoralis and deltoids. You see the biceps. This is the anatomical cadaveric specimen. You see here the long head of the biceps. This is relationship between the plate and the biceps. This is the pectoralis. This is the deltoids. This is the window that I use to introduce the plate. It's important to slide the plate from proximal to distal below to the flexor muscles. During the plate introduction, it's very important to maintain the bone alignment by traction, keeping the elbow joint in flexion and the forearm in supination to put away the radial nerve from the plate in the distal approach. You see here the plate on the distal window. If you use the LCP plates, you can use the guide, the drill guides, as you see here, as a joystick to help you or to hand the plate to introduce the plate during the surgery. I have some friends from Korea, and they describe the use of external fixator to reduce and to maintain the reduction during the plate introduction. This is a very interesting method, but I personally don't use this strategy in my cases. Okay, it's very important tip. Do not use never ever Hohmann retractors during the surgery, because you can damage your radial nerve or musculocutaneous nerve by traction. This is a prohibit. Don't use it, please. Okay, this is a very important tip. You see the plate inside, and I started in the distal incision. Then I identified the center of the distal humeral diaphysis. Not through the plate. I identified the center of the diaphysis. Then I drill the two cortices. Then it is very important, because this prevents to drill a wrong position or more medial or lateral. Then I slide the plate and I introduce the screw, but I not completely tight this more distal screw. Now we go to the proximal approach, and usually I like to check the fracture reduction before to put the proximal screw. This is the time to check and to correct any rotational deviation, taking account that the long head of the biceps must be 9 degrees with the distal bicondylar elbow axis, like in this picture. Okay, if everything is okay, we're looking for and identify through the most proximal plate hole and drive it to the center of the diaphysis to drill and to put the more proximal screws. Sometimes I need to make some correction, like in this case, to align better the fracture under the plate. Okay, if you are using a cortical screw, and this is one advantage to use a cortical screw, I recommend to drive it more proximal to get more bone by the screw. I show you in the case. Then we tight it completely, and we tight the distal one. Now it's time to check the quality of the reduction, and again the alignment of the limb and the shoulder and medial and lateral rotation of the shoulder. Okay, this is the C-arm control. If everything is okay, we can place another screw, proximal and distal, but we need to leave an empty hole between the screws. If you use 2 screws in each fragment, you leave an empty hole between them. You can use 3 screws, no problem. 3 cortical screws, no problem. But if you use only 2 cortical screws, or if you use a locket screws, please leave an empty hole between them. Why? Why? Because it's very important to maintain the work length of these screws and to avoid movement in this fragment. Now, after this, we check the alignment, the bone alignment, and we check the internal and external or medial or lateral rotation. And the final image. This is the tip. If you use a LCP plate, this is the tip that Bruce Siran described with me. We started with 2 conventional screws, in this number 2, in number 2 distal and proximal holes to reduce the fracture with the plate. Then we put the 2 lock-in screws and number 1 and number 3 holes. Let's see an example. This is a case. You see the cortical screws, unicortical screws, and 2 lock-in screws, and a very beautiful callus. After surgery, we start as soon as possible active movement and rehabilitation, total rehabilitation, elbow and shoulder. And the patient after 6 weeks. Okay, let's see some cases. This is a middle diaphyseal fracture with a butterfly fragment. This is a very easy fracture to treat by this technique. It's important in this technique, I'd like to stress the screws inclination in the proximal fragment to gather better fixation, okay? This is the clinical evolution, the patient. This is another interesting case. It's a car accident, open fracture. It's a posterior exposition of the bone. This is, you see, open by posterior and the focus of the fracture. The patient was taken to the operating room, and after washing the debridement, the anterior fixation was done using this concept. This is the patient evolution, and the bone completely healed. Please, attention. I recommend do not fix side-by-side screws, mainly in the proximal fragment. It reduces the work length of the screws and allows this wide shield Whipper movement in the focus with loss of reduction. I show you. For this reason, I recommend to maintain an empty hole between them or to use 3 screws. Let's see one case. This is the case. You see the proximal fragment is a little bit shorter, and the reduction, you see, was not good. This is the reduction. It's not good. This is an oblique and stable fracture. Very difficult to reduce it and to maintain. You see, you can see that the surgeon tries to fix it with a screw in the 3rd hole, but he can't because the reduction was not good. The decision making was to fix using the 2nd hole. Okay, this decision unfortunately was wrong. The correct decision was to reduce the fracture again and better. Okay, let's see what happened. After 12 weeks, the patient came without pain, very satisfied. And he come back to his work as a salesman and doesn't come back anymore in our clinic. We called him for 2 times without answer. Okay, 2 years later, the patient started with pain in his arm after the end of the day and decided to return. This is the aspect of the patient. This is the X-ray, but this is the AP view. You see, in this X-ray, a non-union caused by a bad reduction and progressive mechanical instability allowed by this kind of fixation is using the 2 side-by-side screws. Okay, we indicated surgery, but the patient asked for a while to solve some particular problems and come back 9 months after because he suffered acute pain. This is the X-ray, and you see, maybe if we waited a while, the fracture could heal, but we decide to treat it. Okay, the patient is okay now and return to normal life. We decide to make an open anterior approach and to treat this fracture. You see the fracture completely healed. Another point, another tip, do not use 3 or more locking screws in each fragment because it increases the stiffness and reduces the callus formation. This is a very nice example. This is a transverse fracture. You see, in this fracture, we use 2 locking screws in each fragment, and cortical screws in the center of these 2 lock screws. You see, very good callus consolidation. But this is another case. You see, 3 locking screws in distal and 4 screws in proximal. Okay, 15 weeks, no healing, no bone formation. Many screws, no mark movement between the bone fragment, no callus formation. It's very important to avoid this. This is a doctor complication, not just a fracture complication, not just a method complication, it's a doctor complication. And another important point, if you see in the posterior aspect of the arm, you can see here the radial nerve crossing the posterior aspect of the arm. And it's important not to use distal or, not to use screws in the middle part of the humerus from the anterior to posterior because you can grab the radial nerve in the posterior aspect of the arm. Screws in this position is very dangerous for the radial nerve. Another recommendation, this is it is not it's a very interesting, is the screws fatigue or pull out is not common, but I saw all my cases and I think that we need to be careful with the proximal fragment. This is a case that was treated by this technique. It's a very unstable fracture, you see. It's a short proximal fragment, okay. Callus after 8 weeks, very good. But during the follow-up of the patient, you see here, fatigue of this screw. And then this caught me attention. You see another case, this is from my resident. It's a very short proximal fragment fixed with 2 screws, you see, and you see the pull-out. I recommended in this case to change it and to put another long screw, 3 screws to fix a fracture, and the fracture healed completely without problem. This is another case, and this case was treated in the correct way. You see, this is a short fragment, proximal fragment, 3 screws in the proximal fragment, 2 screws in the distal fragment, leaving empty hole between them. Okay, we talked about transverse fracture, simple transverse fracture. Okay, we need to be careful with this kind of fracture. We can treat this fracture using this technique, but it's very important to get bone contact between the bone fragments and to make a very well-balanced synthesis. If you don't have bone contact, the fracture doesn't heal, and the plate will break. You see, this is a transverse fracture treated by the correct way, you see, long plate, 2 screws in each bone fragment, empty hole between them. Very nice consolidation, very good result. Another case. This is more proximal transverse fracture. In this case, you see the fracture was not well reduced, but you see the both screws in divergent ways, and we got bone contact between the main fragment. This is the key. You see callus evolution and clinical good result. This is another case. Well, in this case, we don't have, it's a polytrauma patient with several other fractures, but in this case, we don't got bone contact. The plate broken, but the fracture heals. Okay, sometimes a surgeon must be luck. This is the final result of the case, but in the majority of the cases, we can have this good result. Then be careful with transverse fracture. Bone contact is the key to have a very good result. We can treat double level humeral fractures. Yes, this is an example. This very good bone consolidation, bone healing. This is another example, both fracture, proximal humeral fracture, and diaphyseal fracture on the right side. This is the fractures treated by conventional plates, proximal fractures, and anterior bridge plate for humeral shaft fracture. This is the clinical result. Very nice. And very proximal humeral fractures can be treated? Yes. This is the patient. This is the fracture. You see here. In these cases, we usually Philos plate, long Philos plate. We do a lateral approach, take care with the axillary nerve. You identify using the fingertip the axillary nerve. Then we make the tunnel. This is the danger zone. We don't use screws in this part of the plate because you can damage the axillary nerve, and a very good recommendation to fix it in adduction, okay? We need to bend into the plate. We make this torsion of the plate. We need to torsion the plate in 80 degrees. You see? Then we introduce the plate from the proximal incision, and the plate goes to the anterior aspect of the humerus. We follow it by imaging this in C-arm. Okay. Then we do the distal approach, and we'll find the plate inside. You see? We find the plate. This is the incision. You see the guide. You see here that the guides are around 9 degrees between them. This is the anterior aspect of the plate and the lateral part of the plate. Now we start to fix. The first thing that we need to do is to reduce the proximal fragment. Then we use a Steinmann pin like Dr. Shiva, and we reduce the proximal fragment, and we start then fixation of the plate in the proximal one with using 1 or 2 screws. Then we go down to fix the distal part. This is the patient, after bone healing, and this is the fracture healed. And the distal humeral fractures can be treated? Yes, of course. We can treat these fractures. We have 2 kinds of distal fractures. We have a distal fracture which the distal bone fragment allowed to fix at least 2 screws in the interior aspect. This is distal, but it is a very easy fracture to treat by a conventional technique, like in this case. We use 2 screws. We put these 2 screws side by side in the distal fragment. It is not a problem to use side by side the screws. And in this case, the patient had a secondary radial nerve palsy. We explored the radial nerve using another approach between brachialis and brachiostylo-radialis, and to treat the radial nerve and the fracture. Okay, this is the evolution, very good healing, bone healing, and this is the clinical evolution. Okay. Sometimes this distal bone fragment is very short. In this kind of situation, you can use the plate a little bit more distal, but I don't like, because you can block it, the fossa. Or another option is to use a phyllos plate upside down, but I don't like to use this technique. My option to treat this very distal fracture is using a Kocher approach, using a normal plate, but I molded and twisted the plate, and the plate is introduced from distal to proximal aspect of the humerus, below to the radial nerve. I make this twist 20 degrees, then I molded the distal part, I bend the distal part of the plate, and this is the aspect of the plate. After I fix this in the lateral column of the distal humerus, as you see here, with 2 screws, and in the anterior aspect of the humeral shaft by 2 screws. We can use the lock-in plate, but this is 3.5 in lock-in plates is easiest to mold it, this kind of plate, and then you can use it in the distal fragment using lock-in screws. You can put 3 lock-in screws. This is the approach, a Kocher approach. You see the bone surface is very important to identify the bone surface. This is the proximal approach, it's a conventional approach. The plate is introduced always from distal to proximal. Here. And you can use your finger to verify the safety of the humeral tunnel. This is a courtesy of my son. You see the finger in the distal approach, in the proximal approach. Then you can introduce the plate from distal to proximal, and to guide this introduction, use your finger, okay? The fracture fixation is made the same way. You start with the more distal screw, then you align the bone, the fracture, and then you put the more proximal screw. Then you fix in distal using side-by-side screw, And in the proximal, you leave an empty hole, okay? Then you can check your clinical alignment. And then this is the X-ray after this procedure. AP view, lateral view, you see. Radial nerve, it's okay. We don't see the radial nerve during this procedure. This is the fracture, 12 weeks, very good bone healing. Okay. This is a very interesting case. Let me show you. This is a male hemophilic with a compartmental syndrome. This is a very complex distal fracture. Which is the best option for this patient? Nail. I think it's very difficult to fix the nail in distal part of the humerus. Open reduction in the hemophilic patient with a compartmental syndrome, external fixator, or MIPO. Okay, we did a fasciotomy of the patient, and by using this fasciotomy, we slide the plate. This was the X-ray after the plate. This is the patient 48 hours post fasciotomy and MIPO. The radial nerve, it's okay. And there's the evolution of the patient with a very good bone healing and very good clinical result. This is the last case. It's a very interesting case because it's a very distal fracture involving the metaphyseal area, as you can see here in this X-rays. You see in the distal, you have a distal bone fragment, posterior distal bone fragment in here. And this patient had a secondary radial nerve palsy. We are using to looking for before surgery the radial nerve, we are using the ultrasound. And in this case, we saw that the radial nerve was not well defined by the ultrasound examination. And this is a very important sign that maybe the radial nerve was damaged, was inside the bone fracture. Okay, this is a tip to find quickly the radial nerve between the brachialis and brachiostelos radialis. The radial nerve is here. You can divide the length of the arm in 2/3 and 1/3, and 1/3 you can find here the radial nerve. Well, that's our hypothesis. The radial nerve is here, and you see here this very interesting dissection. It's a courtesy from Dr. Zeidenberg from Argentina to me. And for this reason, I like more the anterior approach to the posterior approach. You see, the vascularization to the posterior aspect of the distal humerus is more important from the anterior. Then I like to do these fractures by anterior approach. We started with this approach, lateral approach, and you see here the bone fragment and the radial nerve here. It's very interesting image because in this image, you see that the radial nerve is gone inside the fracture. You see? Then we take we take the bone fragment and bring the radial nerve outside and protect it. This is the bone fragment. You see the radial nerve. This is the view, the X-ray, and then we bring, you put the bone fragment inside and bring the radial nerve outside, as you see here. Then we use this DCP plate, molded and twisted DCP plates. It's a normal DCP plate. And we slide the DCP plate like I show you. This is a biological treatment of the fracture. I use these screws. This is a position screw, not a compression. It's not a compression screw. I use these screws to reduce the gap between the main bone fragments. This is the Kirchner wire to maintain the distal part, because you see there is a articular fracture. It's almost not completely, but there is articular fracture. Okay, then you introduce the plate, put another screw to fix this part of the metaphyseal fracture. This is the plate inside. This is the radial nerve. Then we fix the plate with 3 distal screws and 2 proximal screws, like I show you. Okay, this is the final fixation. Let me show you in red, this arrow red. This is the position screws, reducing the gap of the fracture. Do you remember that I show you a posterior bone fragment, and then I try to reduce this distal and posterior bone fragment using these position screws. And this in blue are the screws that are fixing the plate in distal part, and the 2 screws fixing the plate in the proximal part of the humerus shaft. The patient starts his recovery as soon as possible. You see, flexion, extension, and rotation. This was the fracture healed. And this is the patient with completely recovered the radial nerve and very good elbow and shoulder function. Okay, my final message. I think the MIPO nowadays is accepted around the world. It's a very interesting technique and is completely accepted around the world. It's, we can say that this technique is reproducible because we have a lot of papers showing the experience using this technique, and it is efficient and safe. We have many meta-analyses that show the efficiency and safe of this technique comparing with other techniques. Okay, thank you very much for your attention.
Lovely. Dr. Belangero, very, very nice presentation. You're gonna be surprised that I do things a little bit different, but it's lovely to see you and to get ideas on these different scenarios. One message is that we can manage transverse cases. I think that for the juniors, this is very important. We can manage, okay? And you see, it's a beautiful idea, and you use creative ideas to deal with different scenarios, especially in this last case, and beautiful cadaverical pictures, because I learned something in the United States: when you know where the nerve is, you know where the nerve is not. When you know where the vessels are, you know where the vessels are not. This was something that really helped me. So beautiful, beautiful, beautiful. I do things a little bit different, and it's very interesting for us to compare things. Very, very nice. And we have to understand that even with bigger approaches like this last case, many times the biological principles, they can be used. I think that this is a big message. I guess that unfortunately, Dr. Diego has to leave, or can you stay a little bit more, Diego? I don't know.
I apologize because yes, I need to leave to practice now. I am really enjoying the webinar, outstanding concepts. I'm really enjoying it, but sadly I need to leave. Thank you again for the invitation, Sergio.
Okay, lovely, lovely, but we will keep more, a little bit more, because I have interesting things to show. I'm gonna take 20 minutes, and I would really like you both, Dr. Belangero and Dr. Shiva, to make some more comments. But thank you, Diego. Thanks a lot, and we count on you for next events. Okay. Gracias.
Thank you so much.
Gracias para vos.
A pleasure. Thank you all.
Okay.
Bye bye, Diego.
Okay.
Bye.
Shiva.
Just to
Shiva.
add, Dr. Diego, you can see the same on the same link. You can see the recording. Yeah.
Perfect.
Okay. Shiva. Thank you, Diego. Thanks very much. Shiva, your thoughts on the beautiful presentation of Dr. Belangero?
Yes, I agree with that. It is excellent, and really it is always good to see so many tips and tricks from the horse's mouth. I have learned so many tips and tricks from you. Before I met you, Sergio, I had met Dr. Apivita Kokul from Thailand. He presented this in 2009. Yes, I met him in Baroda in India. So I learned the original technique from him, but I modified it after having learned tips and tricks from Sergio. But now from you, Belangero, really I have learned so many minor things, and I was totally attentive for your whole lecture. And really it will be useful to all of us who are using this technique. Thank you very much for that wonderful presentation. Excellent.
Beautiful.
Thank you.
Beautiful.
Thank you very much for your words. Thank you.
Lovely. Dr. Belangero, I'm gonna show my presentation now, and then Dr. Shiva, he has one or two cases, and let's see the different things that I do. And then Dr. Shiva, I think that this is going to be lovely, and it's an honor and a privilege for us and the audience to have you commenting on these different things that I do. I'm really expecting you to, I would say, to tell me your thoughts on what I'm going to do now. Just a second. I'm opening my presentation. Okay, so can you? So
yeah, we can see.
So
yes.
Can you see?
Yeah.
Okay, so I'm gonna start. I'm gonna discuss some cases and some things that I do a little bit different that Dr. Belangero, and it's gonna be lovely to listen to him after that. So the thing is, let's start with a very young girl. This is a transverse fracture, a little bit inferior. And as Dr. Belangero said, you can manage these cases with anterior bridge plating for sure. What to do, this is the technique that I do. There are many messages in this case. Different from Dr. Belangero, I always use the two last screws, the penultimate and the last one, up and down, 12 hole plate, non-locked screws. This plate could be a little bit more inferior, but what I've been learning in 15 years is that as long as you can put two up and two down, you can do the job. So this is the focus just after surgery. I do very, very small incisions. People always ask me, how can I do such small incisions? I'm gonna ask you. This is the proximal, as a rule, 3.5, distal 3.0, but for some reason that I don't know, there is a shrinkage in the distal incision, it becomes very small. This is 8 weeks post-op. What I've been learning is that radiographical callus appear around 10 to 11 weeks, but as long as the patient is doing fine, clinically, everything is absolutely okay. Clinical healing precedes the radiographical healing. This is the mantra of this technique. This is 8 weeks post-op, a beautiful callus. But what I've been learning is that the younger the patient, the sooner you will have the callus from a radiographical point of view. In an elder patient around 70, that will be my last case, things are completely different from a radiographical point of view. This is 4 months post-op. We have to remember that remodeling takes months and years to develop. This is written in Rockwood, Campbell, Jupiter, all of these books. But the thing is, 4 months, she was absolutely okay from a radiographical point of view. But these patients, they get better from a clinical point of view much sooner. This is 4 months in this 21-year-old lady. So this is the proximal incision in the deltopec line, and this is the distal incision that I do a little bit different. I'm going to show you, and we have many keloids in my hospital, which is absolutely out of control. This is 4 months post-op. Let's listen to what I'm saying. I am saying in Portuguese, and I am automatically translating to English. Vamos lá. 6 months post-op. Anterior bridge plate. Você foi operada 29 de dezembro. Surgery 29 December 2016. Então, foi aqui assim, isso, ok. Foi aqui assim. Ok. Tá bom, dobra tudo. Isso, aqui assim. Estica. Ok. Dobra. Tá bom, sobe. A mão lá para cima. Tá, volta. Você quer fazer o quê? Só fala alto. Você quer fazer box? Box. É, she wants to go boxing. Tá. Então, você quer ir pro box. E o braço dói? Não. Absolutely no pain. No pain. No pain. Você nem lembra que tem uma placa aí? Não, não lembro. Não lembra. Ando de bicicleta, de moto, sem problema. She rides a bike and she doesn't remember she has a plate. Tá bom? Então, é isso aí, né? So she has a bike, she doesn't remember she has a plate. How do I establish my incisions to become very small? I'm going to show you many cases. I always draw the incisions and let understand how to draw the incisions. In the very beginning of the surgery, under traction and little flexion of the elbow, you have to imagine that I am looking to the C-arm. It's much easier to understand it looking at the X-ray, but I am looking at the C-arm. Keep this in mind. Always under C-arm guidance and traction. So I'm going to draw my incision between the 2 most distal screws, proximally and distally. And I'm going to draw with a marking pen my incisions, and my distal incision is different, and I'm going to show in a minute. So this is what I do under traction, reduced fracture, delicate, constant traction, and a little flexion of the elbow, always under traction and C-arm guidance. So this is going to be the 2 last screws as we are seeing here with the arrows, my proximal incision, and the same idea. This is going to be here, my distal incision. So from an anatomical point of view, I do exactly like Dr. Belangero in the proximal incision in the deltopec line. This is going to be my proximal incision. It's in the deltopec line like Belangero, but the issue is that I do a little bit different from Dr. Belangero. I go in the interval between the bicipital muscles, biceps brachialis with the distal lateral triceps. And if we see in this picture, this is my distal incision. So medially, the biceps brachii, the brachialis, and we have an anatomical interval here, and I always find the radial nerve as we are seeing here, and I'm gonna talk about it. So the sequence of the surgery, I do both incisions in the way that I have said. This is the magic, constant traction, delicate. I always keep one person only for traction, a resident. You go very delicately. I connect the incisions, and a good tip is that the plate works as a delicate instrument, like an osteotome, but it's blunt, to connect the incisions, always under traction. And this is how I start. I always start with this hole, which is the penultimate screw, and I don't do it through the screw, the plate. I mark the incision, the place, if necessary, under C-arm guidance, and I do the perforation absolutely anterior without the plate. So after that, I introduce the plate from superior to inferior, always under traction. I put a screw in that penultimate distal hole. I go until the second cortical and I come back. And I leave it in the intramedullary canal. So after that, I check reduction under C-arm, always under traction. And I'm gonna drill the distal upper hole, the penultimate screw. I feel very comfortable like that. And after that, I'm gonna put an upper screw till the second cortical, and I come back and I keep it in the proximal. So both screws are partially screwed in only the proximal, the anterior cortical. This is the moment in which I have length, and I'm gonna adjust varus and valgus under C-arm control, and I'm gonna fix the plate with the two screws, and then it's a matter of putting the most distal screws in proximal and distal part of the plate. About the radial nerve, after 15 years, this is my point of view. In the distal incision, I put a Hohmann medially, and I always try to see the nerve, and I find it basically in all of the cases. I identify the nerve with my eyes, but I don't tag it with a vessel loop or any other device. I just see it. I try to avoid a lateral Hohmann medially. So I start with these instruments, a Farabe phalangen back on the distal lateral triceps, the coraco brachialis medially. And one tip that I developed is to use a long artery forceps as a lateral Hohmann, but many times I put a lateral Hohmann and I never have problems with the radial nerve, to be very honest. I use it to tag the radial nerve in the very beginning, but I gave up for many reasons. This is a very old photo in the beginning, but I don't tag it for more than 8 years. So this is the radial nerve. This is another case in the left, very distal case, the radial nerve. We are seeing here the radial nerve, left arm. This is another right arm radial nerve. This is another case that I did in December, the radial nerve. This is another case, a left arm, the radial nerve. I always identify it because I learned it in the United States. When you know where the nerve is, you know where the nerve is not, and it helps me too much to gain space. This is another case, the radial nerve. So how far can we go? Well, I can go extremely distal with this technique. So let's take a look at this case. This is a very obese lady with a complex distal diaphysial metaphysial fracture. If you do posterior plating, is an extreme devitalization of soft tissues, a very big incision. She was quite obese. So my question has always been this: can I put 2 screws down? Well, I can put 1 screw here, and I can put another screw here. So the question I have to ask is, can I put 2 screws? If the answer is yes, I can do the job. Another tip, as long as inconvenient it is, go to the radiological department and get a lateral view. You have a better understanding. So I can put 1 screw here, I can put another screw here. With 2 screws, I can always do the job. In this case, there's no place for mistakes. This is not a case for beginners. This is the radial nerve. This is 1 week post-op. We have to remember that the olecra non fossa is posterior. So if you go this distal, you will not have problems with elbow flexion. I'm going to show you now. And this is the lateral view. I always put 2 screws on the 2 penultimate holes, always non-locked. This is 3 weeks post-op. We have to remember that the mantra of the technique is that clinical healing precedes radiographical healing. So this is 7 weeks. And we have, as we see here in the right, no callus. This is a moment in which the patient is clinically very nice. So you see here 11 weeks, no callus on the left, some callus on the left view, but the patient was very nice from a clinical point of view. So when you come to around 16 weeks, now you have callus, you see on the AP on the right side. And Jupiter, Rockwood, Campbell, they say remodeling takes months, years. So it's just a matter of waiting till you see all of these healed, but it's difficult for me to keep these patients after 4 months under follow-up because they are so good from a clinical point of view that they don't understand why I am following them. I'm just following them because of radiographical documentation. This is the left view with some callus, but it's just a matter of waiting. Now we have 20 weeks. See what a beautiful callus on the AP, right side of the screen. And remodeling takes months, years, but it's difficult to me to keep these patients with me. This is the day I discharged this young lady. This is a beautiful view on the left view, okay? But if you wait, you will see gigantic bone formation here. It's just a matter of waiting, bone remodeling. All of the books say this. So I would like you, my friends, to think about these incisions and think about the gigantic approach posteriorly. And this is why I call this a revolution. 20 weeks post-op, see the size of the incision, extremely small. This is not percutaneous, this is MIPO. Compare it with a posterior approach, uncomparable. I consider this revolutionary. Let's see the motion of the lady after 5 months. She's quite obese, so good external rotation, physiological. Internal rotation was okay. She's gonna show it to us now. She didn't do physio because we didn't have space in our physio department. It's a public hospital, many patients. And this is what I want in the end of the day, a smile in the patient's face. But I would like to show more 20 cases, but I'm going to show 2 more and come to my conclusions to listen to Shiva Dr. Belangero, and especially Dr. Belangero. How far can you go, Sergio? Well, the thing is, I can go extremely far as long as I can put 2 screws anterior. No place for mistakes. Extremely strong man. He goes to the gym. So everybody would say, well, you cannot put an anterior bridge plate. I can, no place for mistakes. And everybody would look at this construction and say, this is gonna fail. I have a very personal way of conducting these cases. 1 week in a sling, and then more 2 weeks only flexion in a sling. And then after 3 weeks, I leave them to move because I have a cartilaginous callus. So this is the patient in the immediate post-op, or something like 1 week post-op. This is 3 weeks post-op, absolutely no callus. But now it comes a very important image. Basically no callus on 7 weeks, but the mantra is clinical healing precedes radiographical healing. So this is written here above. Clinical healing precedes radiographical healing. Let's listen to me in Portuguese and in English. He's absolutely healed from a clinical point of view.
Vamos lá, pouquinho. São 7 semanas, 7 weeks, 7 semanas. Esse é o rosto do paciente. Isso, então vamos lá, cara. Dobra, flex. Isso, estica. Não dói nada. Nada. No pain, absolutely no pain. Tá bom? Dobra agora. Estica, dobra. 7 weeks. Não, você está fazendo físio? Está fazendo fisioterapia? He's doing physical therapy. Ok, cara, dobra tudo. Estica. Faz joia.
Everything okay with the radial nerve. And he was very happy. And after that, it's just a matter of waiting. So see what a beautiful callus formation, because clinical healing comes first and then radiographical healing. It's a fallacy, it's a myth from the word mythology that if you put this distal, you will have problems. I've been seeing this for 15 years. Let me prove this to you now, 5 months post-op.
Então vamos lá, 5 meses de pós-operatório, 5 months post-op. Strongman bridge plate. Sobe, levanta agora tudo, não dói nada. Põe as 2 mãos atrás. Aí, volta, vamos fazer uma flex? Vamos lá, no chão. Isso, isso. Aí, não dói nada.
No pain in the elbow, no pain in the elbow, no pain.
Voltou, beleza? Deixa eu só mostrar novamente. Tá. Faz book aí, ok?
So before showing my last case, I would just like to mention that according to the rules of my hospital, I can show the face of the patient in academical presentations, and according to Federal Council of Medicine in Brazil, I can show the face of the patient in academical presentations. This is international presentations, but I am absolutely under the rules of Federal Council of Medicine in Brazil in showing the patient's face. I just would like to highlight this, absolutely under the law. So what about older patients? This is my last case. So my record is 70 years old, but this lady is 68. So this is, I would say, short oblique mid-shaft. Can you do in 68 years old? Of course you can. Dr. Belangero was talking about contact. I don't have the percentage, but in my opinion, as long as you have minimal contact in between bones, this is gonna heal. But everything goes lower in very elder patients from a radiographical point of view, not from a clinical point of view. So this is the radial nerve of the lady. Pay attention, everybody. 2 weeks, I see obviously nothing from a radiographical point of view. 7 weeks, the 21-year-old girl, a lot of bone, she's almost 70. Her biological response is much smaller. So see here, 11 weeks, basically nothing, and some callus and 15 weeks, but you see on the right side, basically nothing on the AP view, and she's clinically healed. Clinical healing precedes radiographical healing. This is a 68-year-old lady, basically normal external rotation, a little bit of pain in the shoulder for internal rotation. This is the non-operated side. She has pain in the shoulder, some pain, some limitation of internal rotation. We didn't do physio, we have no space. I have no control on that. See the size of the incisions. I'm very proud of the size of my distal incisions. This is not percutaneous, this is MIPO. But I'm very proud of doing such a small incisions with the way I have been developing it. And the proximal is always like this, is not so small, but she's absolutely fine from a clinical point of view. She's smiling, this is what I want. And Sergio, what about X-rays? I'm saying all of the presentation, as long as the patient is good, is a matter of waiting. Some callus in the AP, in the left view, 6 months, some callus, but it will remodel, like Rockwood says, Campbell, Jupiter, and I follow these cases just for radiographical documentation. As I am saying, all of the presentation, wait, and it's gonna appear 8 months post-op in the left view. This is the day I discharged her. She says, Dr. Sergio, I don't know what I'm doing here. So now we see callus, but this is gonna remodel, as I'm saying, all of the presentation. Evident healing in the left view. This is the incisions. I am very proud of my distal incisions in terms of size. This is my last video. I'm coming to conclusions. Absolutely normal elevation, no physiotherapy. I'm not proud of that. I don't have space for all of the cases in a hospital which takes care of 1 million patients. I repeat, 1 million patients. External rotation was basically okay. Some limitation in internal rotation, but she was not exactly unhappy. I was, she was not. Let me show you finally the movement of the elbow. This is, again, the incisions. Still some keloids is very common in my hospital. I cannot control it. It's a genetical thing. The elbow was absolutely fine. And this is the day I discharged her, and she was extremely happy. A smile in the face of the patient. This is what I want. So my final conclusions: you can do ABP in any pattern of, I would say, this is what I like to call, just a second. It's not working. No, just a second. Just a second. In any pattern, this is what I like to call diaphysial fractures, proximal metaphysodiaphysial and distal metaphysodiaphysial, as long as I can put 2 up, 2 down. This is my second take-home message. This is what I do extremely cheap: 12 holes, long, narrow 4.5 big fragments. 2 screws is enough, and I always do with DCP, which is extremely important also in my hospital because we don't have all the money. And these plates, they are much less expensive than Lockheed plates. In the technique I use, don't worry about the musculocutaneous nerve. It's not there in the distal incision because I do it much more laterally. The problem is the radial nerve. My last take-home message: Radial nerve. Respect the nerve, never fear. I learned it in the United States. Be delicate, but this is something that changed my life in the last 10 years. I learned this in San Diego Shoulder, the best shoulder course in planet Earth, in my opinion. Identify and demystify the nerves, all of the nerves. Always respect, never fear, and I feel very comfortable acting this way. Thanks a lot, the panelists, my good friends. This is in Hindi. This is my WhatsApp. I'm gonna leave 10 seconds, and if someone wants to pick it up, and you can write me a message. I'm gonna, maybe if I take some time, I'm gonna reply. And I ask everybody who are interested in shoulder and elbow stuff. I have a YouTube channel with 46 videos, all in English. And this presentation is gonna be there. If you subscribe, you are gonna help me too much. And now I am stop sharing. And I would be delighted to listen to all of you, especially Dr. Belangeira. You can shoot me, sir.
Yes.
Okay. First, Sergio, I'm very happy. I'm very happy to see that the technique that we described many, many years ago is a great success. And
Yes.
I'm very happy to see you follow the recommendations, no? You use the 12-hole plate that I recommended in my first paper.
Sure.
And use 2 screws that I recommended in my first paper, no?
Sure.
I think I'm very happy with everything. I'd like to stress some points.
Sure.
The first one, I've never, based on my cadaveric studies, and I did many cadaveric studies.
Sure.
I've never saw during the surgery or looking for the radial nerve. Okay. The idea is that the brachialis muscle receive fibers from radial nerve and musculocutaneous nerve.
Okay.
And for this reason, I can split in the distal part of the humerus or the arm, I can split gently the brachialis, and then I put the plate inside. Okay, I create this window, splitting the brachialis muscle, and using this technique, I protect in medial part the brachialis, protect, yes, the musculocutaneous nerve, and the lateral part of the brachialis protect the radial nerve. Okay, and I have a paper that I describe it, the relationship, the radial nerve with the plate. I studied it using the ultrasound in the patients that I operated, and I show in this paper that you have a secured space between the center of the plate and the radial nerve. Then I think this is another vision, but I think this is not necessary to expose the radial nerve when you make this distal approach. Okay.
Okay.
This is my opinion, no personal opinion. Okay.
Sure.
Regarding the fixation, I agree that 2 screws, it's enough.
Okay.
It's okay. But if you have a very short proximal fragment, because you have the abduction, you have strong muscles, the deltoids is a strong muscle, I think it's better to put 2 screws, but leaving an empty hole between them, because you increase your work length. Then you fix better the proximal fragment.
Sure.
Because if you put 2 screws side by side, it's almost the same you fix with 1 screw. It's not the same, but I don't know if Yes, more or less. Then
Okay.
I use this. This is another point that I think it's important, okay?
Okay.
But if you have a large bone fragment or a very, a fracture that you can got both fragments inside, I think it's okay, no problem, no?
Okay.
This is another point. And in the distal part, you are correct. If you have space to put 2 screws side by side, it's enough.
Okay.
For the distal fragment. 2 screws you can use side by side. It's enough. No, but sometimes I don't like to put more distal the plate because at beginning during the rehabilitation, the patient sometimes refers difficult to extend the elbow.
Sure.
Pain and difficult to extend the elbow because maybe we can stress the capsule, the
anterior capsule, the
anterior capsule. Maybe I'm not sure about it, but I think.
But I agree. I fully agree.
Yeah, this is the only problem. And if you have a very distal, then you can put these 2 screws. I recommend the lateral column fix in the lateral column that I show you in my presentation. It's another approach. You can use the Kocher approach. It's very easy, and then you displace you slide the plate below the radial nerve. As I showed you. No, but I'm very happy and well, congratulations. You have very good cases.
Sure.
And you are, well, showing and operating this case very well and show this technique for the wart, no?
Yes.
You are,
and I was thinking,
I'm very happy with this.
Yeah, I'm happy you were happy because I was thinking if you would be angry with me because of the position of my distal incisions. But you know, it's a different incision of the same principle.
Yes, of course. The same principle. This is the same principle. You follow the same principle, and I'm very happy to see it.
Lovely. Shiva.
Congratulations.
Thank you very much. Shiva, your thoughts, and you have 1 or 2 cases for us to see your way.
Yes.
But your thoughts.
Anyway, yes, you have done excellent job, and orthopedic surgeon is the one who, for the first time when he does only, he changes from the original one. So I use the original Balaguero's technique of splitting the muscles. As he rightly said, the nerve is from both the sides. There is no harm in splitting in the center. So I am also little worried about seeing the radial nerve. So I like the original technique and I am happy with that. Okay. I'll quickly show my few cases of anterior bridge plating.
Okay.
So, again, a very distal fragment. In 2015, I operated, and you can see the small fragment distally. I just got 2 screws, as Dr. Sergio was telling, and this is at 6 weeks. The patient was very happy, and this is at 1 year follow-up. The fracture has beautifully consolidated, and at 14 months, the patient came for a follow-up. You can see that nice consolidation, and as I said earlier, I normally remove all the implants. The function of the patient, excellent result, all shoulder movements, small incision, and I have removed the implant also in this patient. Any thought about the removal of the implant, both Sergio and Belangero? Yeah. Removal of the implant.
Why you remove this implant, Shiva? Why do you remove it?
2 reasons. It's not a prosthesis that it has to live within the body. So it's always better that the bone takes the original load, and with the implant, sometimes there is a disuse atrophy within the bone. In the long run, there will be some periplate fractures. I've seen quite a few of them which were not removed. So that's another reason. And I have one more reason, my own reason. These are all locally made implants, the total cost of this plate and screw is not more than about $30 US dollars. So I don't want them to be, because I work in a private setup, and cost is a main constraint for my patient because they have to pay from their pocket. All of you are working in a public setup hospitals where you don't deal with this part. So I have to deal with the economy of the patient also. So that is another reason why I remove all this implant.
Okay.
Yeah. Okay. And as I said earlier, orthopedic surgeon is the one who modify the technique in the first instance only. I normally do for a transverse fracture, I pass a TENS. I open from the shoulder first. This is from the anterior aspect I am putting, where I have taken the incision. The entry is somewhere here. So I pass the TENS, then get the reduction, then I apply the plate. That makes my life very, very easy because reduction will be absolutely perfect. This I can remove the TENS at the end of the surgery, or I can retain them because it definitely gives some additional additional support. And anyway, this is here, it is not going to trouble the shoulder, which Sergio is very fanatic about. So I am putting from the anterior aspect just proximal to the plate. Anything?
I like this approach, Shiva. Sometimes I use this 10 from the distal to proximal to stabilize the fracture. When we have more unstable fractures, I use it, and I put the plate and then I take off the 10.
Okay. Yeah,
I like it. It's another possibility.
Yes.
Or use external fixator or use this technique. I like it very much.
Okay, thank you. This is a very narrow medullary canal. Can you do Belangero? Yeah, can you do what you can do in this patient?
Well, if I indicated surgery for this patient, I think we can use MIPO technique. I use MIPO technique for this patient, and I take care to use a long plate, 12 holes, or I need to measure, but a long plate. And in this case, I think it's very important to put 2 screws, leaving an empty hole between them.
Okay.
To avoid fracture.
Anyway, I just forgot to inform. This was a polio lady with a polio. The shoulder is pliable. She is unable to abduct it. She has some power in the wrist, little power in the elbow. But yes, Sergio, any take on this?
No, I would do it exactly, but I don't follow the. I put the 2 last screws. But I would do exactly the same. What calls my attention, it seems to be some pathological bone, and now I understand.
Polio.
Shiva, one question, please. One question.
Yes. Yeah.
There is muscle activity or not?
Not much activity in the shoulder and the elbow. It's only in the wrist.
Okay. Well, this is a very important point because if you don't have muscle activity, the callus is very difficult to be formed.
Yes.
Maybe in this case, open reduction and internal fixator, and internal fixation with compression must be the better option because if the patient doesn't have muscle activity, it's very difficult callus formation. Okay.
Yeah. Okay. Anything to add, Sergio?
No, what I want to ask Dr. Belangero, but I think he fully agrees with me, is that MIPO, or anterior bridge plating, needs good biological response from the patient.
Yes.
So he must be he must have minimal biological ability. And in this patient, I would say that the biological response is not exactly what we would want. So everything would go slower, and in theory, Dr. Belangero, you would fear of losing the construction, not for a mechanical reason, but for biological impossibility. I guess this is what you are trying to say, huh?
Yeah. Yes.
Yes.
Yeah. Okay. Okay.
Yes.
Okay.
Anyway, just to clarify, this polio affects only the motor neuron. So the
Okay.
nerve supply, which supplies only to the muscle for the function, is affected, but the sensation is not affected. And earlier we have operated a lot of polio patients for various reasons. Union is not at all a problem. So we need not have to worry too much about the union of the bone, because sensation is perfectly all right with them. Only the motor power has been lost. Okay, this is just for correction, because in India we see a lot of patients still, though India is now polio free for the last 8 or 9 years. I think 2012 India has been declared polio free, but we had earlier in the 90s and 80s a lot of polio patients with this we have seen. Okay, what I did was, since the anyway shoulder was pliable, I thought of inserting a rush nail from the top and stabilize, and I was able to pass only a 3 millimeter rush nail, and I added that with a radius ulnar plate, locking plate with a simple screw. I have not used a locking screw. I use a locking plate normally, but try to use a cortical screw in them. This is how I treated. This is immediate postoperative picture, and this is after the fracture has consolidated. This is almost about 1 year down the line. Exact dates: June 19th I have operated, 19th June 19, and January 20. You can see after 6 months the fracture has consolidated. This is the, she had some power only in the wrist and hand, that's all. Elbow and shoulder were pliable. So yeah, so it has been used in even in a very narrow medullary canal with a polio also, with just 2 screws above and 2 screws below, and proximally I was able to negotiate the screw by the side of the crush pin. Then last case I am showing, this patient was operated for a fracture of the distal humerus, and it was actually a pathological fracture which was missed. This is he came with multiple lesions, and this was the time when I advised him to that I will stabilize this, because anyway it is going to, he was given a living time of about less than 6 months, so by the cancer surgeon. So I thought I'll put a plate, but he did not come, but within a month he came with fracture. So you can see multiple lesions.
Shiva,
yes, yeah.
Shiva, was it multiple myeloma or not?
It was not a multiple myeloma. I thought it's a multiple myeloma, but it was a very aggressive tumor, which was, I don't remember exactly, because just now I added this case to my presentation. So, but what I did was, as Belangero said, I oblique screws to get some hold. I took out this distal plate and added this. This is how I treated this patient. This is what I have got the final, because subsequently the patient never came back to me. What happened to him, I don't know. This is about 3 months, 2 or 3 months after I initial treatment. It is the last X-ray I got.
Now,
Dr. Shiva, one question.
Belangero, you can speak.
Yeah.
For this last case,
yeah,
nail would be a good option or not?
I thought nail is also good option, but this fracture distally was not healed. You can see this was also to be stabilized. Nail, neither the proximal, it is so much proximally the fracture, and distally with two such
problem was the distal fragment.
And another thing of nailing is, unnecessarily I might be disseminating the fragment, though already there is metastasis, but why to cause any venous blasting of all these thrombus and landing in some trouble. So with that intention, I never thought of reaming or just put an anterior breech plate in this patient.
Okay, thank you.
Yeah.
The thing is, different cases many times deserve different solutions, don't you think, Belangero?
Yes, of course. Very interesting cases, very different solutions.
Yeah.
But the most important thing is to use not the implant, the principle.
The principles.
Correct.
The principle, I think, is the best thing. And for the young guys, the young guys must see which principle we need to use in this case. It's
Yes.
more biological, it's more mechanical. What you need to do. This is, doesn't matter the implant, because you can use nail, you can use plate, you can use nail with plate, everything. You can use external fixator with nail, but the most important thing to start the planning is, which is the most important, yes, the principle that I need to use to solve this problem. I think this is the most important message. Sergio.
But I have one question, which is, I would say, a fantastic opportunity to say something to calm down a lot of Indian, even senior surgeons, which has been telling me for 15 years one problem that doesn't happen. I'm going to explain you why in my reality, but happens a lot in the Indian scenario, and Shiva will agree in a minute. The thing is, in these cases, clinical healing comes much before radiographical healing. This is my experience. And I guess that you, Dr. Belangero, you see the same, I'm quite sure.
Yes,
so
I see the same.
Yes, so just see the problem, and I want you, Dr. Belangero, to send a message to everybody who's watching. The thing is, in my public hospital, these patients, they are on my hand all of the time. They don't go for a second opinion or a third opinion. So, and they are, I would say, not exactly high-level patients from a very high socioeconomical point of view, in a point that they question less. They say, okay, Dr. Sergio, as long as you follow me, I'm doing good from a clinical point of view. So this is different from the office. So if it takes 11 months, 11 weeks or 16 weeks to have radiographical callus, the patient is happy from a clinical point of view, and that's it. He's not going to go to another opinion. But in the Indian scenario, many times they go for a second opinion, and many doctors say bad things about the doctor who operated the patient with a good technique because there is no callus. And, and the patient becomes very nervous, and the doctor becomes very nervous because other doctors are saying bad things about him. I've been listening to this so many times, and they say, Sergio, I don't want to do anterior bridge plating because it's going to take 3 or 4 months to see callus on the x-rays, and many doctors will say bad things about me. And I try to show them that they don't have to care. They have to trust the principle because it's much less morbid.
Yes.
So Shiva, you know that these things happen in the scenario. So before you comment, Shiva, Dr. Belangero, if you agree with me, I guess you do, to send a message to many orthopedic surgeons in India that they just have to wait for callus to appear. And it's not because of that they have to give up on doing this technique. If you can say this to them, believe me, I'm listening for 15 years, that would really, I would say, help me in convincing these surgeons, hundreds, that this is not a problem, this is not part of the game. If you can speak on this, I would be delighted, sir. And then, Eva. So you fully, we are not listening to you.
Dr. Belangero, we are waiting for your comments.
So, yes. So, Belangero, I just want you, I just ask you to comment upon the delay on radiographical, because they fear this a lot.
Okay, I think the main message is when you do this kind of procedure, if you follow the technique correctly, you need to wait that the patient at beginning came without pain. the patient start the rehabilitation, start the elbow and shoulder movement without pain. I think this is the first important message for the young guys. You need to follow your patient, and the most important thing is without pain. Okay, this means that your osteosynthesis has enough stability, and the patient goes, oh, okay. Well, another important message: the callus formation. Okay, this occurs early if you have a multifragmentar fracture or a butterfly fragment. It's nice. But if you have a transverse fracture, it's a little bit later. Yes. But you need to trust in your technique. You need to trust in the biological procedure. This is a biological procedure. You have everything in favor of you and in favor for the patient because you do or you did a biological procedure. No, this is completely different from a mechanical idea, mechanical procedure. No, this is a biological procedure. You have to wait. You have to trust in your procedure. And you have to convince your patient that you are secure, you are trustful. If your patient see you that you are trustful, the patient believes in you and follows you.
Sure.
This is the most important message that you need to pass for your patient. Okay?
Yes.
And you need to follow your patient. You don't leave your patient alone. Don't leave your patient alone. Please follow your patient. Okay?
Yes.
I think this is the main message.
This is the message. This is the message. But Shiva, do you want to complement? Because this is so important for young surgeons to, once they have a good relation with the patient, everything is going to be okay. Good technique and good medical-patient relation. This is so important. It seems obvious, but the young patients, and they have to understand it. Having said that, Shiva, before Dr. Belangero comes for us to start finishing, I would like you to comment this, and as the president of the Indian Orthopedic Association, and as such an experienced nailer, to repeat the message to the young orthopedic surgeons. This is so important. I have a lovely opportunity to have you both to reinforce this. Dr. Belangero had, so now Shiva, please just speak a little about it.
Yes, definitely. I had 100% agree that we had to follow our own patients. Then only we will come to see the complications. Then we know what wrong has happened. To learn ourselves, we are doctors, we are learning every day. So only once we follow our patients regularly, then only we will learn by our own mistakes. That's one. Second thing is, you should inform the patient what is your thought process, so that patient also takes part in that. You inform that this is now whatever I am expecting is not happening. We will wait for 1 more month. Otherwise, we'll take the another road.
Sure.
So that he knows about that. Otherwise, what happens is, if the patient goes to some other doctor, they immediately see. It's always when we have operated, we think that it will unite. We'll wait for more time. But when it is somebody else complication, we take a drastic decision very immediately. So somebody takes a drastic decision, and there will be misunderstanding between the patient and the doctor. So I always tell my patient that I am not seeing callus at present, but I'll expect this to happen. If this doesn't happen, if we have just if you have any complication, I'll treat it. But if you go to somebody, today itself, they'll say that he is going to do this. I tell that option also to the patient, saying that if you go to somebody, that option, whatever the plating, bone grafting, they will be telling, but I am waiting with you. Let's wait for some more time. That having the patient along with you, reassuring them is very, very important.
Yes,
And the last part. Last part is humerus is a non-weight bearing bone. We cannot extrapolate the results of a tibia nailing and femur nailing to the humerus. So in tibia and femur, we can do dynamic locking, allow the patient to walk so that the fracture collapses and comes nearer. But here, if I do a dynamic locking, the fracture due to gravity of the arm itself is going to get separated. So there is no question of dynamic locking in humerus. You have to do a static locking, compress whatever possible on table. And many a time, resorption at the fracture site might be extra in few % of the patient. There, they take lot amount of time. I showed the picture of a doctor, an orthopedic surgeon. It took 2 years or more than 2 years for the fracture to consolidate. A transverse fracture in the humerus, nailing requires at least 1 year to see the consolidation.
Okay.
So don't take a drastic decision of grafting or plating at 2 months, 3 months, 4 months when you don't see a callus. So wait, if the patient is not having pain, wait, it will get united. I have n number of cases to show. So I can show a lot of my own cases from whom I have learned. Thank you very much, Sergio. It was really wonderful. Yeah.
Before I finish, I just want to say that all of you, which are very experienced and represent a lot to international orthopedics, have highlighted to the young doctors that in this both techniques, which are biological, clinical healing precedes radiographical healing. This must be a message, and keep in good relation with your patient, and this is going to be everything. So see, I'm going to finish now because we are 3.5 hours, and I told Dr. Belangero that it would be, yes, it was so nice to me. I am flattered, I am honored to have you both here. This is going to be in YouTube in a few days, and I'm going to send you the link. So just before we finish, Dr. Belangero,
already it is there.
Huh? Yes. So just for you, sir, who is so important, both of you in the international, just to say goodbye to the hundreds of people are saying before we finish, your just quick final words. First, Dr. Belangero, and then my good friend Shiva.
Okay. It was a very pleasure time. It's very nice. I'm very happy.
Good.
Very beautiful cases, very beautiful conferences. I like to know Dr. Shiva. I like to see you, and I like to see the friends from India. Okay, I have to say thank you for this opportunity to Sergio, and maybe we can meet again in another activities.
I am counting on you, sir.
In our activities.
Okay.
Okay. Thank you very much, Shiva.
Okay.
Thank you very much.
Okay, Shiva.
And bye-bye.
Okay, Shiva, just say goodbye to the hundreds or thousands of people who are seeing us.
I should thank Sergio and other panelists today, because I said that it is the weekend and you could accommodate. I know it's a working day for all of you. It's a Tuesday morning. Now it is 11:30 in the morning at Brazil. I know.
Yes.
It was really wonderful to have listened to. I have heard Belangero and through Sergio so many times, but it was really wonderful to hear you personally today, and I learned a lot. Thank you very much. And the orthopedic surgeons who have been watching, at present over 2,500 people are watching, and there will be many more who will see, and they will be all greatly benefited by your wide experience. Thank you very much.
Thank you, Dr. Ashok. Thank you for the opportunity. Do you want to say anything before we finish?
I think it was a fantastic webinar, and especially I believe all the speakers enjoyed themselves. So that was the most important point. presenting cases and discussing them. It was so much enjoyment for all four of you. So I think that was the best part of the webinar. Thanks very much for sharing your experience. Thanks.
So before I finish, thanks, Dr. Belangero. I'm counting on you for next events. Shiva is my good friend, so we are always together. Thanks, Ortho TV. And as we always say, namaste and namaskar. Okay?
Thank you.
Okay, thank you. See you later. Bye-bye. Bye-bye. Thank you.
See you. Bye-bye. Thank you very much.
Thank you.